Is now in session.
I begin by acknowledging the Ngunnawal people, together with the Boonwurrung and Wurundjeri people of the Kulin Nation, the traditional owners of the lands upon which Commissioner Briggs and I meet today, and we pay our respect to their elders, past, present and emerging. Before we commence the hearing, I should just make one or two initial remarks. On 20 March of this year, we announced that we would suspend the hearings at that stage as a consequence of the evolving corona pandemic. It was a difficult decision to make because a number of hearings had been planned. There'd been a lot of work put in place. A lot of people assisted in the preparation of that work, but it needed to be deferred to ensure that there was meaningful engagement and that people, particularly those involved in aged care homes and health department, were able meaningfully to engage with the work of the Commission. However, we have continued working, although the hearings were deferred. Our work has not stopped, and we have been continuing to work constantly on the terms of reference. In that regard, on behalf of Commissioner Briggs and I want to continue to thank the staff that has been working with us and all of those people who have engaged with our staff and with us in ensuring that the work has been ongoing, that we've been able to work within the very restricted times and circumstances in which we find ourselves. We resume the hearings today and we find ourselves still in difficult circumstances, but that work will continue and our hearings will now continue as best we can. One of the consequences of the pandemic has been, however, that some of our work has been delayed. As a result of that, we asked the Prime Minister for an extension on which we needed to report, and we received an amended letters patent with the extension for our final report to the Governor-General now to be by the 26th of February 2021. The amended letters patent are available on our website. However, the time is short. It is perhaps shorter than we would like in the circumstances in which we have, but we will need to press on as best we can. As you will see, Commissioner Briggs are meeting in different locations. That is because of the difficulties that we all have in travel. Melbourne is designated as the official place of these hearings, although we are in fact physically meeting from different locations. Commissioner Briggs is in Canberra and I am physically in Melbourne. We've been assisted in that task by the Australian Government Solicitor, and we need to thank them for the speed with which they've been able to make accommodations and some fairly difficult technical arrangements. We will be hearing from a number of witnesses from across the country. We are very mindful that things have been difficult for the witnesses as well. Some of the evidence will be given by video and some by telephone. It is a very trying time for them, and some of them have had particular difficulties that we are very conscious of. We thank them for their patience and their flexibility in ensuring that the important work that we have been asked to do has continued and is capable of continuing. Unfortunately, there's one thing I need to say as a result of some concerns that was expressed to us by a previous witness. And it is unfortunate that I need to express the remarks or repeat the remarks that had been made by the late Commissioner Tracy in January 2019 at the hearing in Melbourne, in Sydney. Under Section 6 capital M N of the Royal Commissions Act, it is a criminal offence for an employer to dismiss or prejudice an employee who has appeared as a witness or produced a document or given information or a statement pursuant to a summons, requirement or notice issued by the Royal Commission. Where an employer to seek to deter a person from assisting us, this may give rise to an offence if, for example, an institution or individual sought any form of legal redress against a member of their staff acting as a whistleblower seeking to volunteer information to us that would result in very close attention being given to the lawfulness of that conduct and the motives behind us. Section 6 capital M is not limited to employers. It is a criminal offence.
The Royal Commission is now in session.
Well, I apologise for that slight interruption. there was a fire emergency test taking place at the AGS buildings. That interruption, of course, does not in any way derogate from the great thanks that we have for AGS making available the facilities. We remain grateful, and this is one of the many little glitches that happened. On a much more serious note, though, I do need just to complete what I had been saying about Section 6 capital M of the Royal Commissions Act. It is a serious matter for anybody to interfere with.
Your attention, please. This is the second call for the floor warden to attend the whip vote. Thank you.
To interfere with the work of the Royal Commission, as I was saying, it is a criminal offence for any person to use, cause or inflict any violence, punishment, damage, loss or disadvantage, and that word is very wide, to any person for or on account of the other person having appeared as a witness before the Royal Commission or any evidence given by that other person before the Royal Commission. We also view seriously any situation where a person providing information to us through written submissions or as part of our community engagement program, such as public forums, suffer prejudice or disadvantage as a consequence of doing so. Mr. Knowles.
Thank you, Commissioner Pagoni. Commissioners, I'm here with Ms. Erin Hill. I would also like to begin by acknowledging the traditional custodians of the land on which we meet, the Boonwurrung and Woiwurrung Wurundjeri peoples of the Kulin Nation, and for Commissioner Briggs, the Ngunnawal people, as well as the traditional custodians of the lands on which our witnesses appear today, and pay my respects to their elders past, present and emerging. The theme of this three-day hearing is the interface between the aged care system and three distinct aspects of the healthcare system, being mental health, oral and dental health, and allied health. The term interface is used here to describe the relationship, connection or meeting point of these systems. The theme of the hearing touches on a number of the Royal Commission's terms of reference, including those relating to the quality and safety of care provided to people receiving aged care and what the Australian Government and aged care providers can do to strengthen the aged care system. Paragraph L of the Terms of Reference directs you, Commissioners, to have regard to the interface with other services accessed by people receiving aged care services, including the interface with healthcare services. Paragraph I, Roman numeral 5, directs you to consider all aspects of the quality and safety of aged care services, including but not limited to mental health. The premise underlying this hearing is that the mental, oral and dental and allied healthcare needs of older people receiving aged care must be identified and met. Meeting those needs will improve health and well-being of older people and maintain independence and functioning. This hearing builds on the Canberra hearing in December last year. At the Canberra hearing, the relationship between the aged care and healthcare systems was examined more generally. That hearing was premised on what we regard as an uncontroversial contention, namely that people receiving aged care should have access to healthcare services commensurate with their needs on the same basis as others in the community. The evidence at the Canberra hearing established that this is not occurring for many people receiving aged care. It showed that access to healthcare services for people receiving aged care is inconsistent and often inequitable. That inconsistent and inequitable access to healthcare services extends to the distinct aspects of the healthcare system, the subject of this hearing. Aged care recipients, and particularly those receiving residential aged care, are not getting the mental, oral and dental and allied health care they need and are entitled to. Commissioners, during this hearing we will focus on potential solutions. Through the witnesses that give evidence, we will test propositions that may inform recommendations you make in your final report. In particular, we will contend that the mental, oral and dental and allied healthcare needs of older people accessing aged care services could be better met with, firstly, increased funding and alternative funding models. Secondly, improved incentives for healthcare professionals to provide services at an individual's place of residence. Thirdly, greater training for aged care workers and others. And finally, better clarification of aged care providers' responsibilities and implementation of performance measures or performance indicators. In a moment, I will outline some specific propositions we intend to test at this hearing. Before I do, I note that some of the propositions tested at the Canberra hearing or developed following that hearing may have an impact on provision of mental, oral and dental and allied health services for people accessing aged care services. The first of those propositions went to a new primary care funding model for aged care recipients by which general practitioners could apply to become accredited aged care practices and receive funding through a capitation model. An accredited practice would receive an annual lump sum payment for each older person in high-level home care or residential aged care for whom the practice provides primary care. The second key proposition explored at the Canberra hearing was the rollout of multidisciplinary outreach health services accessible to all people living in residential aged care or receiving high-level home care. Psychogeriatricians and allied health practitioners could form part of these multidisciplinary outreach services. The third group of relevant propositions explored at the Canberra hearing went to the need for greater clarity about the respective roles and responsibilities of aged care providers and healthcare providers in delivering healthcare or ensuring access to healthcare. I'll now turn to each of the key areas under consideration over the next 3 days. Today, we will focus on the relationship between the mental health care and aged care systems. Poor treatment of older people with mental health issues came to the fore in 2017, when the catastrophic abuse and neglect of older people at Oakden Older Persons Mental Health Service in Adelaide came to light. The Oakden scandal prompted reviews into the facility and necessarily greater scrutiny of the aged care sector, which ultimately led to this Royal Commission. At Adelaide Hearing 1, Mrs Barbara Spriggs and Mr Clive Spriggs spoke about the experience of their husband and father, Mr Robert Spriggs, at Oakden and the lack of dignity, care and respect for residents there. 5 speakers at the Adelaide Community Forum, held in the Adelaide Town Hall in August last year, reinforced this perspective. At Melbourne Hearing 2, we heard about Oakden's reform process from Dr Duncan McKellar. Dr McKellar was a member of the Oakden Review Panel and co-authored the report coming from that review. The late Commissioner Tracy and staff from the Office of the Royal Commission saw firsthand the results of this reform process at what is now called Northgate House when they visited in August last year. While we have heard about the transformation of the culture at Oakden, other evidence points to the needs of older people with mental health concerns still not being adequately addressed across the aged care system as a whole. In brief, Aged Care Financing Authority data shows that at 30 June 2019, 49% of people in permanent residential aged care had a diagnosis of depression. This was also the case at 30 June 2018. A number of submissions made to the Royal Commission by peak bodies, aged care providers, health professionals and aged care recipients and their families have identified problems with the mental health services available to older people receiving aged care. These problems include inadequate treatment for depression and other conditions, lack of aged care staff expertise in supporting people with mental health needs, and lack of access to the public health system. At Adelaide Hearing 1 and the Sydney hearing, some witnesses expressed concern that aged care workers do not have the knowledge and skills to provide mental health care even if they had the time to do so. Piecemeal funding for mental health care in aged care facilities has created a patchwork of incoherent services causing confusion and gaps. Mental health services which are theoretically available to older people receiving aged care include the care residential aged care facilities are assumed to provide, Medicare benefit schedule funded services, state and Australian Capital Territory run older persons mental health community services, Commonwealth funded dementia specific services, and aged care mental health services commissioned by primary health networks. While the number of service providers might appear comprehensive, each stream has deficiencies, relying on another to fill the gaps. Not all gaps end up being filled. Aged care recipients still miss out on receiving the mental health care that they need. Some examples are as follows. People receiving residential aged care do not have the same access to Medicare-funded mental health services as people in the community do. This can be readily fixed. We will also hear that older persons' mental health services provided by state and territory governments are geared towards older adults who require a very high level of care. This means that older people with moderate mental health needs often find themselves in what one of our witnesses, Associate Professor Stephen McFarlane, calls the missing middle, where conditions are too complex for a general practitioner to manage, but they do not meet the criteria for access to an older person's mental health service. Associate Professor McFarlane also suggests that, in practice, older persons' mental health services often do not reach into residential aged care because aged care is seen as a Commonwealth government responsibility and not the responsibility of state and territory governments. We will hear that in 2018-19, the Australian government committed $82.5 million over 4 years to primary health networks for the mental health care needs of people receiving residential aged care, but that amount is insufficient given the high level of need. Public mental health and dementia services are also funded in a disjointed way, despite the fact that these conditions often coexist and are best treated by teams of similar professionals. We intend to test with witnesses a number of possible solutions. We'll test propositions for changes to the Medicare benefit schedule to facilitate better access to mental health assessments, treatment plans, and psychologists and psychiatrists for people receiving residential aged care. We will also propose an incentive payment scheme for psychiatrists and psychologists to encourage them to attend residential aged care facilities. Additional propositions we will test include increasing funding to ensure state and territory-run older persons' mental health services are accessible by aged care recipients on a consistent and equitable basis. We will also test proposals intended to address loneliness and disengagement in people receiving aged care by providing specific mental health training for personal care workers and harnessing the emerging mental health peer workforce. The Royal Commission has published 2 pieces of research this week regarding community attitudes to ageing and aged care. That research identified broad awareness of the need for social interaction and stimulation as part of maintaining good health. Lastly, we will test a proposition to mandate an explicit and measurable requirement that aged care providers maintain the mental health of residents. We will test these propositions today with a number of witnesses, including geropsychologists, a psychiatrist who specialises in caring for older people, a social worker, and one of the peak mental health sector organisations in Australia. Today and tomorrow, we will hear from 2 direct experience witnesses about their complex experiences with mental health and aged care services. Shortly, we will hear from a witness who will describe her mother's experience of accessing acute mental health care in the community following the onset of depression at the age of 70, then moving into residential aged care and continuing to receive mental health treatment while in residential care. Tomorrow morning, we will hear from Ms. Beryl Hawkins, a 91-year-old woman who receives home care services, about her own experiences with mental health issues. Later today and tomorrow, we will turn to the relationship between the oral and dental healthcare system and the aged care system, and where the oral and dental care needs of people receiving aged care are not being adequately identified and met. Commissioners, this is not the first time this Royal Commission has received evidence about the importance of oral health in aged care. Dr. Peter Fulton at the Sydney hearing and Dr. Adrienne Lewis at the Cairns hearing both gave evidence that people in residential aged care are prone to experiencing poor oral health. We know that poor oral health care is associated with a decrease in overall well-being, including the capacity for speech, eating and socialising, and can lead to a number of significant health issues, including swallowing difficulties, tooth decay, gum disease, and even aspiration pneumonia. We also know aged care recipients, and particularly people living in residential aged care, often do not receive adequate oral health care. There are a number of reasons for this. The most significant reason is the failure to assist residents to brush their teeth regularly and make clean their dentures. Added to this is poor access to the full suite of dental practitioners for people living in residential aged care or receiving higher levels of home care in the community. Those people often have reduced mobility, a consistent factor affecting access to any healthcare service, and there is a paucity of dental outreach services. Dental and oral health care is predominantly delivered by dental practitioners, including dentists, oral therapists and oral hygienists in dental practices. Some private dentists and state government dental services currently provide outreach services to residential aged care facilities, but these outreach services are limited, and not all older people receiving aged care have access to them. These services should be made available on a systematic basis to people receiving aged care. Another reason for poor oral health care is low oral health care literacy levels in the aged care workforce, and in particular among personal care workers. Commissioners, again, we intend to test potential solutions for these problems. First, we propose additional funding be directed to state-based public health dental services to provide outreach services for aged care recipients. This increased funding would be provided through joint contributions by state and territory governments on the one hand and the Australian government on the other of 50% each. Funding for older people's dental outreach services could be effected through the National Partnership Agreement on Public Dental Services. This agreement sets targets for provision of public dental services as well as the responsibilities of respective state and territory governments. The agreement is due to expire on the 30th of June 2021 and is currently being renegotiated. Under this proposition, earmarked funding would be provided to public dental services, which could then either directly provide dental healthcare services to aged care recipients or outsource the provision of those services to private providers. This would facilitate a systematic approach to service provision, with the state and territory public dental services managing the dental care of aged care recipients. We will also propose that the Australian government should establish a new funding mechanism to fund dental and oral health organisations to supply dental therapists, oral health therapists and dental hygienists in residential aged care to carry out regular oral health assessments and to assist with personal care worker education in oral hygiene. We will also test propositions directed to improving oral health training for personal care workers and better evaluating oral health care service delivery by aged care providers. These are practical ways to ensure dental health is protected and maintained. We will test these propositions with dentists, a former dental health administrator, representatives from the Dental and Oral Health Therapist Association, an oral health practitioner, and the Australian Dental Association, New South Wales. Tomorrow afternoon and on Friday morning, we will turn to the allied healthcare system in aged care and its importance for independence and functioning of older people. The Office of the Royal Commission has received submissions, and you have heard evidence that allied health services such as podiatry, physiotherapy, occupational therapy, dietetics and speech therapy can provide essential early intervention, comprehensive multidisciplinary care and restorative care. These interventions make a difference to older people's ability to remain well and independent. Commissioners, witnesses in previous hearings have given evidence about stark gaps in allied health services to meet the needs of older people, including inadequate funding mechanisms. In this hearing, we will test a two-tiered funding solution to improve access to allied health services for people receiving aged care. The first tier would increase funding for aged care providers for the direct provision of what we are calling frequent and ongoing allied healthcare services. These services maintain the health, well-being, mobility and functioning of aged care recipients more generally. Services such as podiatry, occupational therapy, speech pathology, maintenance physiotherapy, exercise physiology and dietetics. Directly funding aged care providers to provide these services would, we suggest, assist the aged care system to focus on ablement, re-ablement and maintenance for all people who need it on an ongoing basis. The second tier of the solution would go to funding the provision of what we are calling infrequent or episodic allied healthcare services. These services are the ones that only some people receiving aged care will need, or services that people receiving aged care may need temporarily as a result of an episode of ill health or injury, such as a fall or stroke, or services that people receiving aged care need, but only very occasionally. These infrequent or episodic allied health services might include rehabilitative physiotherapy, audiology, and optometry. We're suggesting that the Australian Government harness the Medicare benefit schedule to fund access to this group of infrequent or episodic allied health services. Access to these services would be for older people receiving aged care who are referred by a general practitioner. Such a GP could, but need not necessarily, be part of an accredited aged care general practice. Such an accredited general practice is the proposed new primary care model that I mentioned earlier, in which general practices would be funded as aged care specialist practices and can refer patients to relevant allied health professionals. The number of services provided for by Medicare under this process should be commensurate with needs and not limited to the 5 sessions per year funded under the existing chronic disease management approach. In addition, the level of benefit should meet the cost of service provision so providers do not charge large gap payments for allied health services. We will test this 2-tiered approach with allied health practitioners who specialise in reablement and restorative care, a geriatrician who has worked with multidisciplinary allied health teams, practitioners who provide multidisciplinary allied health care to people receiving aged care, an allied health academic, and the Chief Executive Officer of Allied Health Professions Australia. Later on Friday, we will call witnesses representing 2 approved providers. We will ask them for their views on what we have heard over the previous 2.5 days and canvass their opinions on possible solutions. Their evidence will be followed by 1 panel of representatives from the New South Wales and South Australian governments and another panel of representatives from the Australian Department of Health. We will test with both of these panels our proposed solutions for better access by aged care recipients to mental, oral and dental and allied health care services. If I can now call for the operator to display the general tender bundle index, Commissioners.
Mr. Knowles, whilst the tender bundle index is going onto the screen, perhaps if you could go through the process of tendering it.
Yes. The Melbourne Hearing 4 tender bundle, as will be apparent in terms of the evidence, as will be apparent from the index which is to be displayed, consists of 35 documents, and I seek to tender that Melbourne Hearing 4 tender bundle, Commissioners.
Yes, thank you. I think the index is now on screen. That tender bundle will be Exhibit 17-1.
Thank you, Commissioner. Ms Hill will now call the first witness.
Yes, thank you, Ms. Hill.
If the Commission pleases, I call UX.
Yes. Madam Associate, would you swear in the witness?
UX, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Good morning.
Good morning, Erin. Ms. UX, you're giving evidence before the Royal Commission today under a pseudonym, aren't you?
That's correct.
And that pseudonym is UX?
That's correct.
And you prepared a statement which you've signed and which is dated 27 April 2020, haven't you?
Yes.
And have you got a copy of that statement there in front of you?
Yes, I have.
And I'll ask the operator in the hearing room to bring up document ID WIT stop 0747 stop 0001 stop 0001. Ms. UX, do you see a copy of your statement on the screen before you?
Yes, I can see it.
And you've indicated to the Royal Commission that there are 2 changes that you'd seek to make to your statement, haven't you?
Yes, that's right.
If I can take you to page 6 of the statement.
Yes.
And paragraph 48, you've indicated that you want to add the following words to that paragraph. My mum has not seen a geriatrician whilst in aged care. She has seen one recently when she spent some time in hospital.
Yes, that's correct.
And if I can ask you then to turn to page 11. You've indicated that you seek to change the heading that features above paragraph 75 so that it reads, the things I believe should change.
Yes, that's correct.
With those changes, is the content of your statement true and correct?
Yes, it is.
Commissioner, I tender the statement of UX.
Yes, thank you, Michelle. The statement of witness UX is Exhibit 17-2. For the benefit of those on the webcam, I should indicate that the witness is visible to the commissioners and commission staff, but not otherwise visible to the public at large. And Mr. UX, may I say to you that we have read your witness statement carefully. We're very grateful for the time that you've spent in giving us the information that you have. We're very conscious of the difficulty it must have been to traverse some of these matters yet again. But we are thankful, and in particular, we're thankful that through what you've said, you are able to give a voice to you and the others in similar circumstances. So,
Thank you, Commissioner.
Ms. UX, you indicated to the staff at the Royal Commission that there are parts of the statement that you'd like to read out and parts that you'd like me to read out.
Yes, that's right.
Could I ask you to start to read those parts which you seek to read out, starting on page 1, paragraph 4, and the portion of your statement which is entitled Background?
Yes. Shall I start now?
When you're ready, thank you.
Okay. I'm a counsellor employed by a non-government organisation. I counsel people with substance use issues and have some professional experience in mental health related conditions and the mental health system. My mother was born in 1936 during the Great Depression. Money was scarce, but Mum's family were used to making do with what they had. I believe this experience coloured her outlook on life. She was strong, capable and independent. Mum was stoic and sometimes negative, but always persevered through difficult times. Mum and Dad made their living farming and Mum was used to hard physical work. My parents had 4 children, 2 girls and 2 boys. Dad passed away in 1992. Mum's mother passed away in 1994. Mum spent a lot of time caring for them both until they passed away. Mum moved into her late mother's house and lived by herself until moving into an aged care facility in 2010. Mum loved her local community and kept busy with groups such as the local CWA and Neighbourhood Watch. She drove her elderly friends into town regularly so they could do their shopping. Just before turning 70, she won a Community Spirit Award. Mum was always a very fit and active individual until her first episode of depression in 2007. Mum is currently 83 years old and lives in a high care residential aged care facility. My sister has taken the lead with managing most of the following issues.
Thank you. And with respect to those issues that you've just referred to, they are the issues that you set out in detail throughout your statement, which Commissioner Begoni has just referred to, aren't they?
That's correct.
And under the section of your written statement on page 11, you've got the heading, things I believe should change.
Yes, that's right.
And it's that portion of your statement which you've asked me to read on your behalf.
Yes, that's right.
Which you say is your reflection of the issues that yourself and your family has confronted in accessing mental health services for your mother.
Yes, that's correct.
If you're content and comfortable for me to do so, I'll commence reading from paragraph 75 at this point.
Yes, thanks, Erin. Please go ahead.
Things I believe should change. Paragraph 75. To improve the care of older people like Mum, I believe medical professionals and facility staff should listen more to us as Mum's family, as the family knows the needs of their relative best. I do not think that my siblings and I have unrealistic expectations for Mum's care. When we have raised Mum's low moods with the facility staff and told them this isn't normal for Mum, the staff assume that just because Mum is in her 80s and frail, that she has dementia. And even though Mum was probably fitter than me and had a better social life before she entered the facility, I have lost count of the number of times I've had that conversation with staff. Paragraph 76. I think that there needs to be better communication between the various stakeholders involved in Mum's care and better care coordination. Mum's care coordinator within the older person's mental health unit is a position that is reassigned to a different person every 6 months, which I believe disrupts the continuity of care. Mum feels as if she's being passed around and we feel like we're always playing catch-up. Older people are a diverse and vulnerable group and would benefit greatly from person-centred care. I believe better partnerships between stakeholders overseen by dedicated care coordinators based at aged care facilities would provide continuity of care and reassurance for the family and their loved one. Paragraph 77. Sometimes I wonder whether the facility staff and at times the staff of the older person's mental health unit even read Mum's whole file. Something as simple as having an easily visible note on top of Mum's file at the facility, similar to an allergy alert, to the effect that Mum, quote, tries to take herself to the toilet and is at falls risk, would be an improvement. Paragraph 78. Some of the failures of communication that I've noticed in my mum's care include: point 1, the facility does not do what the GP asked them to do as set out in the statement. This includes clinical care, such as wound care, and seems to be due to a lack of training. The aged care facility staff do not follow instructions in wound care for mum's ulcers, even when detailed information is provided on paper and via email by the GP, despite the facility contract stating complex wound care is provided. They appear reluctant to change their practices or to be open to new practices. Point 2, there also seems to be little communication between the facility, GP and the older person's mental health unit. I've had to ask the GP to ring the older person's mental health unit to sort out mum's medications. The GPs are usually very good. However, as mum is a patient of the practice, we deal with a lot of different GPs. Point 3. When mum is taken to and from the older person's mental health unit, her belongings are left at one location or another. We have received many phone calls telling us to, quote, come and pick up her things. My sister doesn't drive now, and we both live 35 kilometres from the hospital. I've had to tell them that this is not reasonable. Paragraph 79. We have tried to access Mum's MyGov and My Aged Care records, but we have found it very difficult and have not been able to get access. We haven't received a reply to the letter we sent to MyGov. Dealing with Mum's care and well-being is traumatic for my sister and me. It has been a constant disappointment. I'm aghast at how things don't happen that you would take for granted, such as different people involved in Mum's care communicating with each other. I would expect that if people say they will make a call or provide a service, that they will. Even though my sister and I are not physically caring for Mum, it is exhausting having to be her constant advocate. Paragraph 81. For Mum, I wish those who care for her would understand and appreciate that Mum is driven by purpose and provide social activities that reflect that, not just entertainment and activities to occupy time. Paragraph 82. Mum is of a generation where there is still a lot of social stigma surrounding mental illness. There needs to be a conscious effort to speak with people of my mum's generation in language they understand about mental health and the resources available to help them. Like the initiatives regarding men's mental health, I think there should be something for the older generation to tell them, quote, "You've been strong all your life and soldiered on, but it's okay to talk about mental health." Ms. Ewicks, that's the portion of the statement that you've asked me to read.
That's correct.
And Commissioner indicate that concludes the evidence of Ms. Ewicks.
Yes, thank you, Ms. Hill. And Ms. Ewicks, I do want to repeat what I said earlier on by way of thanks to you for coming forward and being available for this public statement. It is your account of what happened in relation to your mother really is a very lamentable account, and one that regrettably is not isolated. We really are grateful for people like you coming forward and telling us of your experiences, difficult as it must have been to relive. So thank you.
Thank you, Commissioner. Thank you. And thank you, Erin.
There will now be a short break, I understand.
Yes, I'm told that the next witness is not available until 11:15. So I think, will you be taking that witness, Ms. Mills?
Mr. Knowles.
Mr. Knowles, is there anything that we need to do between now and then, or should we just adjourn until 11:15?
There's nothing I'm aware of for the Commission going on. Subject to your views, we can just adjourn until 11:15.
Yes, all right. Well, the Commission will now adjourn until 11:15. Madam Associate?
Royal Commission is adjourned until 11:15. The Commission is now in session.
Mr. Knowles.
Thank you, Commissioner Gurney. Commissioners, I now call Dr. Alison Argo and Dr. Diane Corsa.
In session.
Dr. Argo, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Dr. Corsa, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Yes, Mr. Knowles.
Thank you, Commissioner. Dr. Argo, can you tell the Commissioners your full name?
Yes, Alison Argo.
Thank you. And Dr. Corsa, can you tell the Commissioners your full name?
Diane Corsa.
Thank you. Dr. Argo, you prepared a document entitled Response to Royal Commission into Aged Care Quality and Safety, Adelaide Hearing 5 Draft Propositions. Now, that document has been uploaded and there's the document ID number RCD.9999.0362.0001, and there should be displayed on the screen a copy of the first page of that document. Do you see that?
Yes, thank you.
Thank you. And that is a 7-page document dated the 9th of July, as I understand it, prepared by you?
Yes, correct.
Yes.
It says the 8th on the top of the page.
Yes, the last page, Commissioner, goes to a slightly different date. Although, as the Commissioner has just observed, the first page refers to the 8th of July, though, doesn't it?
It certainly does, I'm sorry.
No apology necessary at all. Can I ask you, Dr. Argo, have you read that document lately?
Yes, I have this morning, thank you.
Yes. And are there any changes that you wish to make to the document?
No, except for apologies about the date.
Yes. Well, was there one particular matter that on the third page under Proposition M5, you'll see about 4 lines down the words assessment to psychiatrists?
Oh, yes, sorry, I thought I'd already, I'd flagged that change. I didn't realise I'd doing that again this morning. So yes, please, that word needs to be changed, assessment for psychiatrists.
Thank you very much. Right. Subject to that change and the date on the first page, Dr. Argo, are the contents of that statement true and correct to the best of your knowledge and belief? And are the opinions in it genuinely held by you based on your expertise?
Yes, they are.
Thank you. Seek to tender the statement of Dr. Alison Argo, Commissioners.
Yes, thank you. The statement of Dr. Alison Argo will be exhibited 17-3.
Thank you. Dr. Corsa, you have prepared a statement dated the 2nd of May 2020, and that has been uploaded with a document ID number of RCD.9999.0342.0001. Now, there should be a copy of the first page of that statement on the screen before you. Do you see that?
Yes, I can.
Yes. And that statement dated the 2nd of May 2020 is 8 pages long and signed by you.
That's right.
Yes. And have you read your statement lately?
Yes, I have.
And are there any changes that you wish to make to your statement?
No, there's not.
Thank you. And are the contents of your statement true and correct to the best of your knowledge and belief, and are the opinions in that statement genuinely held by you based on your expertise?
Yes, they are.
Thank you. I seek to tender the statement of Dr. Diane Corsa dated the 2nd of May 2020.
Here's a statement of Dr. Diane Corsa, will be exhibit 17-4.
Dr. Argo, you are a qualified clinical psychologist and clinical geropsychologist?
Yes, I am.
Yes, and Dr. Corsa, you also have the same qualifications?
Yes.
Yes. Dr. Argo, you have 19 years of experience working with Queensland Health in 3 regions, including regional and rural areas?
That's right.
Yes. And you've been exclusively involved with older people's mental health and people with dementia and their caregivers over the 19-year period?
That's right.
Yes. And you've also taught dementia-specific aged care Certificate 3 TAFE students for a number of years?
Correct.
And you are presently the co-chair of the statewide Dementia Clinical Network?
Yes, I am.
You're currently working in the position of Advanced Psychologist Geriatrics at Sunshine Coast Hospital and Health Service?
Yes.
And throughout your work, you have worked in community, outpatient and inpatient settings, and in particular in multidisciplinary teams?
Yes. Yes, I have.
Briefly, can you say what those multidisciplinary teams were?
So I was very fortunate, I think, that my first ever employment with Queensland Health was in North Queensland for the aged care assessment team. And back then, so that would have been 2001, the aged care assessment teams actually had funding for dementia-specific positions. And I think I was fortunate because I feel that I was essentially raised by a multidisciplinary team. So I was trained by the physio, by the OT, by the nursing staff, rather than just having a psychology-specific view of the people that we were assessing. So I think on reflection that's probably what's created my sort of strong advocacy for the true multidisciplinary teams.
And so that was in the context of an aged care assessment team that you worked in a multidisciplinary way?
Yes.
Yes. And are there other ways in which you've worked in multidisciplinary teams?
So within Queensland Health, most team structures are based around doctors, nurses and allied health. So probably the majority of my career I have worked within that team structure, which again I think is the optimal way to care for people if the teams truly are multidisciplinary in that everybody gets a chance to contribute to the person's care. I currently work in a slightly less team environment in that I'm out on my own in outpatients and I just support several different types of doctors in dementia assessment, but I still maintain quite a multidisciplinary approach in that I'm linking in with various community, allied health and nursing staff to be able to deliver that care.
Yes, thank you. Dr. Corsa, can I turn to you? In your work as a clinical psychologist and clinical geropsychologist, you have had extensive experience since 2011 in older people's mental health programs and treatment of people with dementia and their families and carers.
Yes, that's correct.
And from 2018 until recently this year, you worked part-time as an embedded psychologist in a residential aged care service in regional Queensland.
Yes.
Can you briefly tell the commissioners what that role entailed?
That was a part-time position where I came into a 154-bed facility and worked as a psychologist there, delivering individual and group treatment to residents. I was also involved in mental health training with the aged care staff and supervised psychology students as well.
Thank you. Since 2018, you've also worked in a consultancy role with the Primary Health Network in the same region.
That's correct.
And in terms of that role, what have you been, what does your work involve there?
Part of the consultancy was moving around this PHN region and speaking to aged care providers, geriatricians, GPs, and finding what model of care they wanted or thought would be delivering facilities. Based on that, we developed an integrative model of care. Following the consultancy role, when that was completed, I started managing other mental health clinicians, training them and managing them as they went to other aged care facilities and delivered individual and group psychological intervention.
Yes. Do you regard, in terms of that particular model, the Primary Health Network model, as having adequate funding in terms of providing sufficient services to cater for the mental health needs of people in residential aged care, or do you think it's deficient in some way?
I think it'll prove to be deficient in some way. Like any new program, it's growing, and I think it will probably outgrow that funding at some point. There'll need to be some type of management to ensure that it has equitable access across the region.
Yes, you raised that issue of equitable access. Is it fair to say that there's a fair degree of variation in the services that are available from one PHN to the next?
I expect so.
Yes. And can I ask you this? What's your view overall of the extent of involvement of PHNs generally that they have in the activities of a residential aged care service for people's mental health care needs?
Can you clarify what you mean by that?
To what extent do you find that PHNs are able to, Primary Health Network is able to actually get engaged in the activities of a residential aged care service to improve the mental health services that are provided to people in residential aged care?
I think they do it through the service providers and ongoing oversight over that, just ensuring that it gets into all the different parts of the region.
Yes, thank you. Now, both of you have responded to a set of draft propositions relating to mental health services for people receiving aged care. I don't propose today to go back over what you have said in writing, but can I ask you both generally, and I'll start with you, Dr. Argo, does the suite of draft propositions for mental health, that is the improvements to the Medicare benefit schedule, increased funding and access to older persons' mental health services, improved training and clarifying the role of aged care providers, do those proposals address the full range of issues about mental health and aged care that you see as existing, or are there other things that you think would be worthwhile that could be introduced to improve that situation?
Probably the main thing that I thought of in actually sort of putting together for this Royal Commission, and it really got me thinking more about, as I said, my strong belief in multidisciplinary teams, and sort of the place I've come to think about is in terms of just like with the individual older person themselves, that you can't just address mental health in isolation. or their physical health in isolation, etc. I think that these propositions are best viewed from a holistic point of view, in that if we're just focusing on the mental health, we're not, for example, potentially capturing the physical and the cognitive needs of the person. And so I think the main thing, apart from, I think it lays the groundwork, the main thing I'd like to sort of add to it is, again, with that theme of addressing all a person's needs and not just their mental health stay in isolation, the best way to do that is a multidisciplinary team. And I think the theme that seems to be forgotten, this is my opinion, is that a multidisciplinary team doesn't just address the assessment and treatment and get that right. What it actually does is it provides a really rich training field, or nursery, if you like. And I think it's been forgotten when we're trying to address educational needs, which I think everybody's in agreement that there's always going to be a need for, and a need for increased education in aged care. And we've got, wonderful organisations like the dementia research centres and all sorts of things. But I think we've lost that appreciation of a multidisciplinary team where you can only learn so much at TAFE or at uni, and it's actually in the workplace. And in the workplace, you certainly aren't going to learn from peers who are equally inexperienced as you. So having those true multidisciplinary teams, I think it would pay to develop a short, medium and long-term educational plan, because having the experiential or on-the-job training, if you like, I believe is crucial to creating or growing a larger skilled aged care workforce. And I think if we don't start thinking in terms of 10, 20, 30 years from now, that we may get caught out in that we won't have anywhere near enough skilled staff to deliver. So at that point, you're throwing a lot of money in whatever way, shape or form, but if the skilled staff aren't there to deliver the care, it's not going to be effective. So that's the conclusion that I've come to.
Thank you, Dr. Argo. And Dr. Corsa, can I ask you for your response to my initial question about the propositions that are put forward and whether or not you regard them as addressing the full range of mental health issues in aged care, or whether you think there are other changes that you would like to see in particular?
I think building on what Alison says, beside the multidisciplinary teams being also a great training ground, we also have to ensure that we continue to work within this team and within a team. And in order to do that, our funding has to support that. So I think we want to be very mindful that any funding model that gets put forward doesn't create another fragmented system where we've got psychologists working in isolation and not within a team. So often our funding drives our service delivery, but in fact we want a service delivery and the appropriate evidence-based treatments to be driving the funding. So in that case, we just have to be mindful that we need to be funded where we might be spending time with either family or clinical staff or geriatricians or in case conferences, anything that can encourage us to act in that collaborative way for the benefit of residents or older people. They just require that much more collaborative approach, I think, because of their various cognitive and physical issues.
Yes, thank you.
If I might ask, please, Dr. Corsa, how is that possible? How can we fund nationwide to support a multidisciplinary teams in residential aged care facilities or in home care, which are often much smaller than bigger hospitals that I'm sure we're all familiar with?
I think you can still use that better access model through the Medicare, but the funding may be also expanded so that sessions can be funded that we have with other team members. Currently, one of the limitations of better access is that we're only funded when we're actually seeing the client. So we're not funded for case conferencing or anything like that. So it just needs to be, the parameters for that need to be expanded. Once that's available, it's possible that somebody could spend, it's more advantageous to spend longer periods of time within the aged care centre because you're being funded for all the different type of work that you might do, the different interactions that you might be having with people.
Can I ask you now, I wish to take you to one of the draft propositions, and in particular the proposition M2, and you've seen these propositions and responded to them. As I understand it, you are largely in agreement with proposition M2, save for expressing some hesitation about the ability of that job to be done by psychiatrists alone. Am I right about that, Dr. Argo and Dr. Corsa? Sorry, the proposition will be brought up on the screen in a moment, I believe.
I think I mentioned a workforce issue, that there wouldn't be enough psychiatrists to actually do the work and perhaps not enough psychiatrists trained in geriatric work.
Yes, and that difficulty, you would say, could it be addressed by telehealth over time, or you just think there aren't sufficient psychiatrists in the workforce at all, Dr. Corsa?
I am not sure. Telehealth will certainly make a big difference. I think that would be a welcome addition. Alison, you might be more aware of geriatric psychiatrists.
I think it would be a risk in lack of numbers, because certainly there's many psychiatrists out there that, for example, specialise in children's psychiatry or adult mental health, and I understand the difference between the private psychiatrists and the public older person's psychiatry that I've worked with. But in every region I've worked in Queensland, the 3 regions I've worked, I've always felt that there's, access to psychiatry is quite difficult in terms of either people not being able to afford to see private psychiatrists or the usual wait lists and restricted access to public psychiatry. So I'd have concerns that it wouldn't be timely enough.
Well, the draft proposition, which you'll see in the document that's just been brought up on the screen, it's on the 3rd page, I believe, and it's in bold text and marked proposition M2. Perhaps that text could just be enlarged for the benefit of Dr. Corsa and Dr. Argo. So that proposition also does contain, in respect of the proposed new MBS items, time limits in which the person would be assessed initially, that is within a month of entering residential aged care, and then a time limit in respect of the review of that initial comprehensive assessment that is no more than quarterly. So does that feed into your concerns, Dr. Argo? If this proposition were to go forward, you'd have a concern about it just being psychiatrists who were responsible for preparing these assessments and reviews?
Yes, I'd be concerned that those timelines would end up doing 2 things, either driving psychiatrists to do, fast and quick assessments of people that they haven't spent, quality time with, or indeed if those timelines become meaningless in that there's wait lists and they just blow out, that the actual staff on the ground, so in the community or the aged care facilities, they'll stop referring because that mentality of, it's too long a wait. And I see that all the time at work. The GPs stop referring to the geriatric service because rumours go round that there's an 18-month wait. And so then we get a lull because everyone stopped referring, and it doesn't mean that the need's not there.
Yes. So can I ask this, if it isn't just to be confined to psychiatrists, this proposition, who else do you say ought to be able to prepare, and perhaps if I turn to you, Dr. Corsa, at this juncture, who else do you say ought to be able to undertake these initial comprehensive mental health assessments and then the regular reviews?
I believe clinical psychologists, when they're trained to be able to make an adequate assessment.
Yes, and do you see there being any difficulties with a clinical psychologist doing that if there is a need for prescription or referral for prescription of medications as such, or some other psychiatric treatment being required?
Generally, we use a biopsychosocial model, so we would be considering medication and things in that as well, but we'd certainly be wanting to speak to a general practitioner about that, find out.
Yes. You've referred to psychologists possibly performing the assessment. Do you think that general practitioners could equally well perform the assessment?
Yes, I think so.
Yes.
Yep.
Dr. Argo, do you have a view on that topic?
I do. I think that a certain set of GPs could, and I think that typically the best delivery is from people who self-select, so GPs that are interested in mental health and interested in aged care. I think if the governance is around that they're also quite capable, and I firmly support that clinical psychology not only have the training, but our training from the get-go involves working in conjunction with doctors. Like, it wouldn't cross my mind to actually work without the person's GP and specialist, if they're on board. In fact, I'd be quite nervous ever doing my job without the support of the medical fraternity. So, and I think, again, that harks back to that true appreciation of what it's like to deliver services as a team.
Yes. Can I ask you this? If a psychologist were to undertake this assessment or this review, it may well be that might result in the person who prepares or reviews the plans and assessments also being the person who implements them. Do you see any difficulty with that scenario in terms of potential issues of accountability or conflicts or something of that nature? Drago? Yes.
Yeah, I do. I thought of it. Definitely, the conflict is definitely there. And again, I think good governance around that means it's not impossible. I think that psychology, again, our training actually has a great deal of ethics included, which some other disciplines don't have, ingrained in their training. And so, whilst it's not impossible, I think you have to put that out on the table and make sure that those assessments aren't driving, unnecessary need for treatment. I very much doubt that would occur, because my experience is that the need out there far outweighs even the psychology workforce. We've had such a dearth of identification and assessment of mental health problems in the elderly that even there's never going to be enough of us probably in my lifetime to feel that need anyway. So I think that my bigger concern, even though that conflict of interest is there, my bigger concern is actually around still having accurate identification of mental health issues in people in the community and in nursing homes, in aged care facilities. And that was the main point that I pulled out of Proposition 1 and 2 is without skilled staff, we're going to continue to identify, and if the personal carers, for example, aren't identifying, they're not aware of the signs and symptoms, then those mental health treatment plans aren't being asked for in the first place. So I think actually that's the bigger problem, is working out how to identify all these people in the first place.
Well, I guess what you led to there is the question of putting to one side the existence of an NBS item in these terms, whether or not this should be a requirement that is imposed on aged care providers by way of some regulatory framework or quality standard, such that there be a specific and explicit requirement for, on entry, a mental health assessment within a certain period of time on entry into residential aged care, and then perhaps subject to need, a regular review of that particular mental health assessment and plan. Do you think there should be some express requirement of that kind in standards or regulatory provisions, Dr. Owen?
I 100% do, because I think, like driving any change, it takes a good deal of time, and setting it up in the standard, even so, won't fix it overnight. But I think it goes a long way towards when people are aware that they need to meet that for accreditation. It gets them looking into education and getting them thinking about what they need to do. And certainly we're seeing that play out, for example, in the hospitals at the moment with cognitive screening has now been put in the standard for inpatient, and yet I'm in a couple of working groups looking at how to increase education, because general staff are still struggling with that and the meaning of that. So you put it in the standards, and then you expect it to take several years after that before it really starts to turn into the considered and compassionate approach that we want.
Yes.
I actually was, to be honest with you, I was shocked that it wasn't already in. I wasn't aware that it wasn't already part of a holistic assessment. If I was to put my mum or dad in a facility, I had no idea that it wasn't already built in. So
yes. Dr. Corsa, can I ask for your views on this particular topic about standards and the like, whether or not there should be something more specific stipulated, and if so, what? Whether it would be akin to what is set out in Proposition M2?
Yes, I think absolutely we need to create mental health assessment as just usual standard of care. It can't be something, that is just sort of done occasionally or ad hoc. It's such an important element of people's quality of life and how they adjust and how they manage in their later years, that it should be just standard care.
Yes. Thank you.
Might I ask, do you consider that this should be an issue for people with high-level packages as well as those entering residential aged care? High-level home community care packages, sorry, I should have said.
You happy if I answer that, Di? Commissioner, I definitely do. That's my sort of bread and butter really, has been working out in the community with those packages. But I would be reluctant to stop there, again, because I think the wording alarmed me in that proposition, in that I was worried if people were simply on the wait list for a level 3-4 package, that again they wouldn't have that extra access. I'd much prefer to see that comprehensive appreciation of the whole person is happening right from the beginning, right from the first ever My Aged Care assessment, which is a bit tricky because they're not clinicians that are doing those assessments, and that the mental health, again, in the older population, can't be separated out from cognitive health. It's impossible to, in fact. And we're way too focused on their, physical health and reducing falls, building strength and functionality, etc., without appreciating the mental health and the cognitive things that are going on. So those things should be being assessed from their entry into My Aged Care services, and not waiting, until there's a need for higher care in the community, and certainly not waiting until they've reached the point where they've entered an aged care facility, which probably brings us full circle to, if we were doing this holistic care from the get-go, we would obviously be helping people stay in the community, and less people would be needing to go into those aged care facilities in the first place.
Yes.
Yeah, thank you.
Thank you. Dr. Corsa, just following on from the questions that we've heard in respect of residential aged care and some sort of standard that might be required in residential aged care. As we've heard earlier, you have worked in residential aged care yourself. You're an embedded psychologist in a facility for a couple of years. From your experience in that work, how do aged care providers best identify and meet mental health care needs for residents?
How could they could do a lot better. I don't think there's a lot of awareness of mental health issues. There's a lot of reasons that they're not being identified because they're being attributed to older age or this is part of ageing. So it hasn't been done very well. I don't think it hasn't been on their radar. They're aware of the mental health issues, but there's a bit of hopelessness and helplessness that we can actually improve people's mental health once they enter the age group. So they haven't had that experience where they see an improvement in people's mental health because of the engagement with psychologists. Because psychologists just haven't been working in aged care in Australia. So I think that would naturally change, and it did do in the aged care centre I was working in. They began to see the value of how that we could work well together, and that there could be improvements in people's mental health with proper treatment.
Thank you. And I think you have referred in your statement to the need for some sort of dedicated central referrer for residents, families and staff in residential aged care. What do you have in mind there? Who might occupy that kind of position?
The model we've been using has been the clinical nurse because they kind of have oversight over all the residents. Bits of information can come from different areas and they tend to be able to synthesise it and then establish if there's a need for referral to a psychologist. And that was just to make it more manageable, manage the demand of the service and to try and ensure that we access the right people because the funding was limited.
Yes.
They tend to have a bit more knowledge around mental health, and we could have more direct conversations with them to help guide them in that as well.
Yes. And would that person also be a person who is committed to mental health more broadly, not just of the residents, but also of others, such as staff and families of residents and the like?
Yeah, that's right. Sometimes the clinical nurses sort of acted as a manager of the staff who are working under them. So definitely had those conversations with them about how they were supporting the mental health of their staff, and just in those meetings it prompted them to think more widely. Of course, there's individual variability between the clinical nurses and how much experience or knowledge they had around mental health. So some of them did it better than others, so that because there hasn't been a real standard that they had to meet to be in that role.
Can I just ask, on the topic of families of residents and staff and their mental health, how important is that, not just for them but also for residents in your experience?
Very important for the residents. If their families, if the carers are burned out, or the families don't understand what's happening with their parent, or the staff aren't feeling well enough to engage with this person, it can really impact on the residents. You see disengagement, and where staff's attitude changes toward people, they lack that empathy when they're overworked. Families kind of remain absent; they're not connected so much because they're feeling quite helpless themselves. So yeah, it's really important.
Just on that point of the importance of mental health care services for staff and families, it's true, isn't it, that the primary health network model, that is delimited just to providing mental health services to residents and doesn't extend more broadly to mental health care of their families and the staff who care for them?
That's right. Although you can spend time with families and other staff members, as long as that time is regarding the clinical care of the resident, so it's not specifically about their own mental health.
Yes. Now, in terms of your work when you were an embedded psychologist, Dr. Corsa, can you tell the commissioners how that role was actually funded? What was the source of funding for your employment at that residential aged care facility?
The university applied for local council funding, and for which they were successful, but it was only short term, and when that ran out, the aged care facility funded me.
I see. So the aged care facility funded you out of the funding that it received more broadly for the residents. Is that what you're saying?
That's right, yeah. They saw the benefit of having a psychologist there, and they funded that role. They continue to fund that role.
Yes. Can I ask you both, how commonly do you see that in aged care?
I've not seen it.
Dr. Argo?
I saw the position advertised and was very excited and hadn't seen it before. It's something that's been on, something I've wanted for, 20 years. I watched it closely because I was very concerned that if somebody didn't take it, that we'd lose the opportunity. So I'm very excited.
How often, pardon me, and is the position ongoing? Can I ask that, Dr. Corsa? While you may have left the position, does somebody else, as another psychologist, replace you in that position?
When I left the position, we put in clinicians that were funded under the Primary Health Network funding. So there's ongoing psychological support, but it's being funded in a different way.
Okay. And why do you think it's not more common? You both said it's something that you've very rarely seen. Why is it not more common? And perhaps I can start with you, Dr. Argo.
I actually think that comes back to some quite sort of endemic lack of education and understanding. A lot of the staff in aged care facilities are not clinicians, and then you might have one RN, which obviously isn't even the highest ranking sort of nurse training that you can get. And I think there isn't an appreciation or understanding of the mental health or cognitive needs, and sort of people associate psychology with therapy, and that's it. So just true lack of education in the first place. And I think when I was working with those clusters of staff, I had the same experience as Di, where you can quickly, quite remarkably, make an impact, because not only are you looking after, for example, challenging behaviours and helping them with that, but because you're able to actually look after the staff themselves and their own feelings, you actually can build up the culture of the whole facility and the whole workforce. And a lot of them haven't experienced that before, so they're not actually aware that it's available to them.
Can I take you to another of the draft propositions? And this is at the fourth page of the document to which you were taken before. It's proposition M3. So it's actually the page numbered 0005 in the document that was brought up before. And you'll see the bold text there of the proposition, and that is that there be a new NBS item for psychologists providing services pursuant to a mental health treatment plan to Australians living in residential aged care with up to 15 services in a 6-month period, and that the benefits should be commensurate with the schedule of recommended fees. You both largely agreed with this proposition. One of the things that comes out of what you've just said, Dr. Agar, is do you think that the item should be extended to apply to other allied mental health professionals, such as social workers and the like?
I think that as long as you have the governance around training, there's some really good specific mental health trained staff. And again, my opinion is that the need is going to far outweigh, one particular discipline being able to address our aged care people's needs. So I think that you can't, the same theme, you can't separate out and work in isolation for mental, on someone's mental health without, for example, training the family. It's the same in dementia care. People presume that I'm going to work with the people with person with dementia, when in fact the majority of the work I do is actually with their direct family and with the service provider going in. It's not with the person themselves at all. It's actually surrounding them. And so mental health is the same. I think there's definitely room for well-trained staff. So you could, because, for example, if I try and get an OT or a social worker on board to help with one of my people with dementia, if they're not trained, I actually get a reply back saying, oh, I rang such and such and she said no, she doesn't need it. So I think having properly trained mental health practitioners, could be social work, could be OT, is a really important component, because otherwise sometimes the symptoms themselves get in the way of being able to help the person.
Yes. Dr. Corsa, this proposition would effectively give people living in residential aged care access to more NBS-funded psychology services than older people who are living in the community more broadly. Do you think that's appropriate? And if so, why or why not?
I think you're dealing with a population that have, they're in care for a reason, so there's a lot of complexity in their need, and sometimes that does require more sessions with, as I said before, with people who are involved in their care. So due to that complexity, it could be warranted. I think when people are in high care and community, they also probably require similar level of care. And just on what we mentioned before on the workforce, I would just add to that, like mental health social workers and mental health nurses who can be very, very good at providing these services to residents. I think provisional psychologists also shouldn't be discounted, because I think that's where our future workforce is coming from, and we need to begin that training, and that will encourage a wider workforce development.
Yes, thank you. Now, you will have also seen a draft proposition M5, which is a couple of pages on in this document, and I'll bring that up for you now, together with a few of the paragraphs that follow it, paragraphs 20 to 22. You'll see there on the screen, paragraph 21 observes that there's no standard framework for delivery of older persons' mental health services. And I wanted to ask you, Dr. Argo, some questions about that, because you yourself in your statement have observed that there's a lack of consistency in service provision between different older persons' mental health services. On that question of consistency, is that a measure that could be alleviated or fixed by way of a funding stream through the National Health Reform Agreement and stipulations in that about eligibility and the like to ensure better consistency?
To be honest, Council, I'm not sure, because I put that in there on purpose because I've had many years of frustration with that inconsistency, because that older person's age group, there's so much overlay between mental health and cognition. It really is essential that you've got that consistency in a really thorough way. And I think I've written in my submission that up north, for example, there wasn't one psychiatrist that was interested in dementia. So we had no specialist dementia services for many years. It was myself and the GPs, the local GPs. And then we had the opposite in West Moreton, where the older person's team was a very functional team who actually took on board all of the sort of most difficult dementia assessment and care across the region as well. That to me was the optimal model. So if you could have governance and the funding could create older persons' mental health services where they included dementia care. I know a lot of older person psychiatrists are actually very committed to this idea, and they frequently talk about wanting to have multi-specialist memory clinics, for example, where you've got a psychiatrist working side by side with a geriatrician. So yes, if the governance around the funding could insist on that skill set and insist on that inclusivity, then I think it's a possibility. But I'm not sure what other barriers would come up in terms of the inflexibilities within the public health service itself. I couldn't answer that.
But your point, Dr. Argo, I take it, is that the funding needs to be dedicated in such a way that there is recognition that mental health for older people must also involve an assessment of dementia care and involvement of dementia care as well?
Yeah, starting with the appreciation of assessing their cognition, and it's similar for adult mental health, to be honest. Some regions have neuropsychology working side by side to assess that cognitive function, but many don't. So they're delivering, in my opinion, half a service. And the other point I think I put down is my concerns about historically, and this is in more than one region, historically the public health mental health services really do stick to the pointy end of presentations. And we have, it's anecdotal, but we have a saying, unless they're actively suicidal or actively psychotic, you've got no chance of getting your referral through. So again,
that's at the older person's mental health service.
And adult. So they, again, the funding would have to come with quite strict instructions about, improving that inclusion criteria for referral.
Yes. And in that regard, in terms of that severe end of the cohort, do you think the public mental health services that there is, what's the degree of access for them in terms of going into residential aged care? Is it consistent? Is it adequate in your experience, Dr. Argo?
I actually think I can only speak from the areas that I've worked in. And again, I think the lines have always been blurry because you've got federal agencies like DBMAS, the Dementia Management Behaviour Advisory Service, and now the Severe Advisory Service, who are funded and meant to be doing that role. But when that system falls over, the local area turns to, for example, the public hospital for help. I know that our local public area, I believe, does a reasonable job from a geriatric point of view, but I'm not sure, to be honest, I don't have enough to do with them. I'm not sure from the older person's mental health how much or how little they're going in. I know down at West Moreton we didn't have enough ability. The numbers were too high, and even though we were a very functional team, we couldn't go out to every nursing home and help them with every person that was having mental health problems or behaviours. So,
yes. Thank you, Dr. Argo. Dr. Corsa, do you have anything to add in terms of those public mental health services and the extent and nature of their involvement in dealing with aged care recipients' mental health symptoms?
Yeah, I think they're also being variable across different regions. I know further north, the aged care centres pretty much feel pretty hopeless in referring, because unless it's extremely severe, they can't get services in, and so they tend not to refer then. I think in our region it's a little bit better. But there's some variability in how they can respond, and that's probably because there's a perception that demand has been higher than they've been able to provide.
Yes, thank you, Dr. Corsa.
This is an issue, isn't it, about the balance between treatment and prevention. And I know in the materials we have, or the submissions we have before us, which I think you've also read, there's an enormous return on this kind of investment. So would you say that the reason you can't get these services, apart from the workforce issue, is that funding is definitely rationed, or what do you think is behind these problems?
Di, you want to go first?
I guess we're talking about a public health system here.
Yeah.
Yeah, and their funding, I guess, if they don't have enough, I don't know. Alison, working in
I think that again, looking long term, that the focus should be on getting in and providing that good quality care from the beginning. I would expect that the payoff down the track is that we won't need as many services at the pointy end, particularly for mental health, but quite frankly, the same works for dementia. If I get in with a family and put everything in place and put the education, it's very less likely that it all sort of turns into a disaster and explodes at the end. And I think mental health is very similar. If you put in those supports, not just for elderly people living in the community, that easy access that we haven't had before, and in aged care facilities where we've had no treatment for mental health, I think if you put them in, then through some of the existing services and funding methods we've got already, I think then you can have a very pointy end public service that could not do it on its own, but I think work nicely, dovetail in to come in for the really difficult ones. And again, I think that's the same principle as some of the pointy end dementia services. It's really for that top 1% or 5%, and the rest should be bottom up prevention. And we can't sort of look at that short term, can we? We need to sort of map it out now.
I just have one last question for each of you, and that relates to draft proposition A5. That is a different document, but you have both, I think, seen that and considered it. And in particular, if I can take you to that draft proposition A5 and the accompanying table, which will be displayed shortly on the screen. So you see there the initial text and the table also. Can I just ask you, you've seen how this creates different funding streams for, on the one hand, frequent and ongoing allied health services, and on the other, infrequent or episodic allied health services. And at least as configured at the moment, there's a allocation of psychology in infrequent or episodic. Can I just ask you for your views about where psychology actually properly fits in this, whether it might be one or other or both, and secondly, whether or not you see merit in this model overall, or whether you think that there is some other model that would be better at funding, providing funding into aged care to address aged care recipients' mental health issues. Perhaps if I start with you, Dr. Corsa.
I think just on that wording of infrequent, probably with psychology, it's more about episodic, and that can be quite intense treatment at a point in time, and then that might occur again at another point in time with a resident. So we just have to be careful again that it could drive a fragmentation of the system. So we want to keep that continuity of care if we could have the same practitioners delivering those episodes of care as they're needed. So I think we just need to be careful in the wording of that model, that it doesn't create that lack of ability to collaborate and have good care, ongoing care with people who know the resident and know the aged care facility and that they trust working in aged care. I can see the potential for initiative.
So I just lost you there momentarily, Dr. Corsa.
Sorry. I just said
Same.
just being careful that it's not that the services would be infrequent. It's more about episodic, but that just have to be careful that we maintain continuity of care in that model.
Yes. That would then mean, though, that it falls within the category that is the subject of referrals by virtue and funding under the Medicare benefit schedule. Do you see that as appropriate or otherwise in terms of the model as it's cast?
I think it can be appropriate as long as people aren't, psychologists don't become external to a team. So if the funding's adequate, if it's modelled correctly to include families and care staff and things in a way that encourages psychologists to spend more time in the aged care centre, rather than just breezing in and breezing out. Contractors sometimes do that, and they're actually working in isolation instead of working as part of the team.
Yes, thank you, Dr. Corsa. Dr. Argo, can I turn to you in terms of your thoughts on the model and psychology's place in it?
I'm not sure, again, I prefer not to talk just about mental health so much as the entire person's needs, because as I was saying, that I struggle to separate them out. I had an issue with this in terms of, in some ways, the division between those frequent and ongoing are all of the classic physical things. So I think I did an example in my document about classic rehab services, for example, and the focus has always been on a person's physical functioning, and a lot of time and effort goes into that, and private rehab and public rehab services, for example, will have plenty of OTs and physios, and all of that's automatically thought of, and I think the presumption that the person's mental health and cognitive health is needed less often, even though that might not be the presumption there, I think it has that possibility of dividing, which is this historical problem I have between the physical needs and the, some people call them the soft or the less important needs of mental health and cognition, and it really gets my goat up. And I think if we don't change this perception now, we have that risk of reinforcing that for another 20 or 50 years, and it's not just me, it's not a small thing. This is really what you find out in the community. You'll go into an aged care facility and they'll be about wound management and falls, and you go into the hospital and they're really struggling, as I said, with the new standard of cognitive screening. There's such a lack of emphasis that I think any model like that, you can have the split funding, but I wouldn't like to see a division between specific allied health discipline if it's going to reinforce that historic problem.
Yes, and in terms of frequent and ongoing services, it's not to suggest that the model is cast in a way where mental health and wellbeing services wouldn't form part of those frequent and ongoing services, just that they would be undertaken by people who would be funded through the aged care provider, whether it be social workers, whether it be others, but it may even be that there are others. How would you see that working in terms of the direct funding?
I think the model that sits best with me is a flexible model where you could have both. So certainly I was a bit confused. I think I put in there because it says something about the money sitting with the aged care provider, whereas our new system moved away from that, and we have the money sitting with the person. So if I get a level 3 package, the money sits with me, and then I employ Blue Care or whoever, but the money sits with me. So I suppose maybe it's just in the wording, but that the obligation is on the service providers and the aged care facilities to be able to provide that suite of allied health services. And I think you could have a mixed model funding where you had some built in to the packages, which, as I said, I'd like to see from level 1. I think it's pointless waiting till people have high care needs and then putting stopgaps in. So I think you could have some money sitting with the aged care facility, the obligation sitting with the service providers and aged care facility to provide some, and then perhaps overlaid by the second type of funding, which is through the MBS.
Yes.
If that's what it's talking about, then it could be good. Yes.
Thank you, Dr. Argo. Dr. Corsa, Dr. Argo, I have no further questions for you. Thank you very much for your time.
Thank you.
Commissioner Briggs, any further questions, Commissioner Briggs? Dr. Corsa and Dr. Argo, thank you for making yourselves available today, and thank you for responding to the questions that have been put to you more formally. It's been very, very helpful. It certainly helped our thinking a great deal. Thank you both very much.
I hope so. Good work. Thank you very much for the work you're doing, and I'm watching with excitement. And I'm very grateful for the 6,000 new packages that the Royal Commission has already achieved for us. Thank you so much.
Thank you both again. Both witnesses should be excused.
Yes, if they could, and I believe that Ms. Hill will call the next witness.
Thank you. Thank you. Thank you both, and you're formally excused for further attendance.
Thank you.
Thank you.
Yes, Ms. Hill.
I call Associate Professor McFarlane, Stephen McFarlane.
Associate Professor McFarlane, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say aye.
Thank you. Yes, Ms. Hill.
Good morning, Associate Professor.
Good morning.
Could I ask you to please state your full name?
Stephen Robert McFarlane.
Then, could you please provide a description of your professional experience and background for the Commissioners?
Sure. I've probably worked in old age psychiatry almost exclusively for the best part of 23 years now. Since 2003, I've been a geriatric psychiatrist with certified training from the Faculty of Old Age Psychiatry under the College of Psychiatrists. I've had work experience as Director of Psychiatry in 2 metropolitan Melbourne aged psychiatry services, where the scope of my practice has included memory clinic work, inpatient aged psychiatry work, and multidisciplinary community work. Since 2016, I've been working with Dementia Support Australia as Head of Clinical Services. I'm also in private practice and have been so since 2003, and I'm involved in Alzheimer's disease clinical trials and have authored 31 academic publications in the area of old age psychiatry.
Now, you've been a witness in the Royal Commission previously in Sydney.
That's correct.
And for the purpose of this hearing in Melbourne, you prepared a statement which you've signed and is dated 20 March. And I'll ask you if you've got a copy there in front of you.
I do.
And I'll ask the operator to bring up document ID WIT stock 0740 stock 0001 2022-0001. Is the document that's been brought up on screen the statement of which I've just described?
It is.
And are there any changes that you'd seek to make to that statement?
I have no changes.
And are the contents of that statement true and correct?
They are.
In addition to that statement, Associate Professor, you prepared a response to draft propositions document. Have you got a hard copy of that in front of you?
I do.
And if I could ask the operator to please bring up document ID WIT.9999-0339-0002. I'll just see if that's able to be brought up. I might move past the anticipation of bringing that up on the screen and ask you.
It's possible that your number might have been incorrect, or that it was part of the other document.
Thank you, Commissioner. We have prepared a response to draft propositions that the Royal Commission has asked you to consider. Associate Professor?
I have.
Commissioner, I seek to tender Associate Professor McFarlane's statement and response document as a bundle.
Yes, well, the two will be Exhibit 17-5.
Associate Professor, at paragraph 11 of your statement, you describe to the Commissioners the burden of mental illness amongst older Australians in residential aged care as being extremely high. Could I commence our time with you by asking you, what is the relationship between an older person's mental health and well-being and the residential aged care setting?
Okay. There's a relationship between the mental health of all people and their physical health and their well-being, and the mental health burden rises upon entry into aged care. Unfortunately, most of the prevalence estimates we have about the burden of mental disease or lack of well-being in the older population has actually excluded people who reside within residential aged care. So we have population estimates which don't take into account those very high-risk groups, and aged psychiatry services are funded accordingly so that the true need is underestimated. But those studies that have looked at the burden of mental illness within the residential aged care population have found, for example, that about 50% of residents will meet the criteria for major depression at any one time. And the statistics around the prevalence of dementia in residential aged care settings and associated behavioural and psychological symptoms of dementia in that setting are also well known.
To what extent do those symptoms, the behavioural and psychological symptoms of dementia and mental illness overlap in a residential aged care setting?
Well, the true prevalence estimates of dementia in residential aged care are about 50% will have a diagnosis of dementia at the point of entry into care. There's probably another 20% who develop dementia whilst in care but lack a formal diagnosis. There's clearly a big overlap in those numbers with the 50% estimate prevalence for major depression in that setting. In addition, you have a background incidence of major mental illness across the population who age and enter into residential aged care. So about 1% of the population will have schizophrenia, another 1 to 2% will have bipolar disorder. There's significant numbers with personality disorders as well. The biggest risk factor for a mental illness in any individual is actually the presence of another mental illness. So dementia is a risk factor for other illnesses, and there's some evidence that chronic conditions such as chronic depression can also be risk factors for dementia, so there's a vast overlap.
We've put you on notice, Associate Professor, that we're seeking to draw out from your evidence today solutions. And you responded to the propositions that are draft propositions that have been prepared by the staff of the Royal Commission that are under consideration as potential solutions.
Yes.
With that background understood, what in your view should approved providers of residential aged care be doing to identify those needs, those mental health, mental illness and wellbeing needs of their residents?
I don't think that providers are best placed to do that because it's not an easy task. It's not an easy task even for trained doctors. It's not an easy task necessarily for psychiatrists with only general training. It does require special skills to identify the particular mental health diagnosis that might be affecting a person at the time, and the provider and the provider's staff are not best placed to do that at all. You need at least some medical or allied health training in order to enable you to identify illness in this group. And unless you're an employee of the provider in that capacity, I don't feel that providers should be compelled to identify it because it becomes an impossible task for them as such.
The commissioners have only recently received evidence from doctors Argo and Corsa, who are both clinical geropsychologists, who have indicated they would be supportive of an embedded model with a psychologist embedded in a residential aged care setting. Is that something that you've had the opportunity to consider in your experience?
I did view the testimony of those two witnesses. It's not something that I've heretofore considered, though. I am unaware of any facilities that do operate that model, and I believe the previous witnesses weren't aware of many other examples either. Whilst I think it's a good suggestion, there are workforce limitations even on the availability of psychologists, I would suspect, that might prevent it from being a practical proposition. There's not that many, as far as I know, geropsychologists around. Our two witnesses before being notable exceptions, but to staff each residential aged care facility in the country with a geropsychologist, I think we'll run into the same workforce limitations as there are upon aged psychiatrists, and simply substituting any psychologist without specific training or exposure to the particular needs of people living within aged care is not going to value out either, in my view.
Can we then take it back a step, Associate Professor, and look at that first port of call, identifying the issues, assessing the mental health needs of the aged care resident? In particular, we asked you to consider proposition M1, which I will attempt to record up onto the screen, and I'll refer to, I believe it is up on the screen already, proposition M1, and it contemplates the role of funded mental health treatment plans that are prepared by a general practitioner for Australians living in residential aged care. In your response to that proposition, I'll summarise, if I may, that you have a concern with that assessment taking place where there isn't necessarily follow-up of those assessments. Do you see a role for the provider of residential aged care to be involved at that stage of the assessment?
Well, if somebody is preparing a mental health treatment plan, the person who's probably best placed to determine the mental health treatment needs would be the general practitioner. My issues with mental health plans as such is that I'm not aware that they necessarily have been evaluated in terms of their outcomes, and I'm not convinced that there's a benefit of having a mental health plan as such over and above the traditional process of a general practitioner identifying a health need that they themselves can't meet and making a referral to an appropriate provider. That's been the model in general practice for decades, and I'm not necessarily convinced that a mental health plan brings anything to that. Certainly my involvement in mental health plans has been limited to general practitioners sending me a copy and asking me to sign it, which I duly do, but I can't recall an occasion where I've subsequently been asked to provide input over and above what's contained in the mental health plan that I would not normally have been providing were I to have received just a standard referral from a general practitioner.
You identify in response to that proposition that it achieves the obstacle of inequity that presently confronts those in residential aged care where they don't have access to the mental health treatment plan. But bearing in mind your concerns about the utility of such a plan, what would you like to see? What mechanism would you encourage such that there is equitable access to mental health services for older Australians in residential aged care?
Okay, I think there's probably two things that should be considered. The first is if you want to increase the exposure of private psychiatry to people who are living in residential aged care, the Medicare benefits schedule needs to be adjusted to reflect the opportunity cost of travel time to provide services in those facilities, because at the moment aged care providers tend not to provide transport to private practitioners' rooms. They don't see that as their role. And if a private practitioner is given the choice between continuing to work in their rooms for 3 hours or spending 1 hour travelling to a facility, an hour providing service for which they're remunerated, and then another hour travelling back unpaid, economics dictate that they will choose the former. So that's one way of addressing it. The second way would be to improve funding to existing aged persons' mental health outreach services. We heard from our previous two witnesses that a patchy response is currently received by public aged persons' mental health services. But the way those services operate is in a true multidisciplinary fashion. They may be led by a psychiatrist with registrar support, but they'll have mental health nurses, mental health psychologists, social workers, occupational therapists, and occasionally neuropsychologists on the team too. So increasing broadly the access of people in residential care to existing service providers in the form of state-funded multidisciplinary teams would, in my view, be the best way in which public dollars could be spent to support this service. There are, as our previous witnesses have outlined, workforce constraints in private aged psychiatry workforce, and even if the funds were made available to make this a worthwhile task for private practitioners, the workload would rapidly swamp the availability of the private workforce to provide it. So my preferred mechanism would be through increased funding of existing multidisciplinary public aged psychiatry teams.
Drawing out those challenges which you referred to around workforce in psychiatry, and it's been touched on by the previous witnesses, what in your view can be done to overcome these workforce challenges where there simply aren't enough psychiatrists or psychologists with this degree of specialisation for the work that's required?
I think aged psychiatry as a profession probably needs to market itself a bit better. If you look at medical students going into their career, I've yet to meet one who has gone into medicine with a burning desire to be a geriatric psychiatrist. It's something that you tend to fall in love with only if you have exposure to the specialty. The opportunity to get exposure to aged psychiatry, even within specialist psychiatrist training currently, is quite limited. It used to be the case that aged psychiatry was a mandatory training rotation within the College of Psychiatrists training curriculum for new psychiatrists. That is no longer the case, and it's become no longer the case not because the college doesn't see value in an aged psychiatry rotation, but because the number of trainees who need to complete their training within a 5-year period exceeds the number of training positions that the public hospitals have made available for registrars to rotate through. So at the end of the day, this comes back to the level at which public aged persons' mental health services are funded by the health networks. If funding is cut and the ability to establish new registrar training positions is curtailed, then there are flow-on effects to the exposure of registrars to aged psychiatry. It limits the number of aged psychiatrists that we can train and puts a cap on the workforce into the future, unless increased funding is made available for the purposes of registrar training. Again, the solution seems to come back to improved funding of existing state and territory-based public mental health services. That would enable an increase in the size and reach of the multidisciplinary teams, but it would also create more training positions to enable the College of Psychiatrists to give increased exposure to their trainees to the specialty, and then increase the chances that at least some of those who've had that mandatory exposure will then go on and become specialist old age psychiatrists.
So, Professor McFarlane, if I might ask, what is the college's anticipated requirement for these professionals within the system to meet at least the current level of need, if not the future? And what is the college doing in terms of these training positions?
The college can only advocate for the creation of training positions if the college takes the view that a particular health service does not provide a sufficient variety of training experiences to meet the college fellowship requirements. They can choose to de-accredit service for registrar training, and that's probably the biggest stick that the college can wield to exert pressure on the health networks themselves. The Faculty of Old Age Psychiatry within the college is pursuing advocacy for a return to the mandatory resumption of an old age psychiatry rotation. The college is considering that through their education committee structure as we speak. The first part of your question, Commissioner, has escaped me. If you could remind me, please.
Sorry, I'm playing with my microphone a little bit here and having a bit of trouble. My question was, what is the extent of unmet need in this area that the college might have identified?
Okay.
And what's the college's strategy for doing something about it?
The college currently is not able to create a strategy to address the workforce shortage, whilst the number of training positions available for registrars to complete an old age psychiatry rotation remains low. It becomes a bit of a catch-22. You can't mandate a training position if the position doesn't exist.
And how are those training positions increased? Is that your second reflection, which is that more money needs to go in to do that?
The health networks set aside a proportion of funding for registrar positions in all areas of medicine, including psychiatry. The amount of funds that they allocate to the aged psychiatry service could be used to create training positions, but they also need to fill other specialist multidisciplinary team roles as a set quantum of funding. Ultimately, the health service decides how many registrar positions they're prepared to fund out of the limited funding pool.
Thank you.
Associate Professor, in your response to Proposition M5, which is at stop 0008 in the document basically before the screen, you indicate to the Commissioners that you are supportive of a draft proposition that contemplates increased funding to outreach services, but you also raise concerns as to how that funding would be acquitted. Could I ask you to expand on those acquittal issues that you've flagged in your response there and what you consider could be done in response to those challenges?
Certainly. In most states and territories, the state or territory government will provide to the health network a quantum of money for the provision of psychiatry services, for example, and within that there will be a quantum of money for the provision of aged psychiatry services. In services I'm aware of, the actual state funding that is provided for aged psychiatry There's no compulsion on the health network to actually spend that money for the purposes for which it's intended. It can be diverted to other areas of need within the health network, and aged psychiatry, again, to a greater extent even than adult psychiatry, serves as the poor cousin to acute medicine in health services planning and priorities. I don't know any health service, for example, that promotes itself on the basis of being a centre of excellence in geriatric psychiatry. It's all about the transplant unit or the trauma centre or the number of ICU beds. If there's a pressing need in a high-profile area within a health network, that service is always likely to be subsidised at the expense of less high-profile services, which typically include most subacute services, but including aged psychiatry, it's seen as the low-hanging fruit for when budget cuts come along. So the solution to that, in my view, is to have or to make health networks accountable for the expenditure of funds that are allocated for the purposes of providing aged psychiatric services to that purpose. So ring-fencing the funding. I believe there's a model in Western Australia where the state government funds a body known as the Mental Health Commission directly, and it's then the Mental Health Commission, rather than the health networks, that funds psychiatry. That is one model that might bear further examination. Ring-fencing the funding and requiring health networks to make an annual acquittal of how it's dispersed would be another.
With the move away, with the Independent Housing Pricing Authority moving towards a system of activity-based funding for mental health, if that was introduced, in addition to the evidence that you've just given around acquittal and ring-fencing, would you see that dealing with the problem of mental health funds being diverted elsewhere?
Not necessarily, Council. There's been various attempts to model activity-based funding in psychiatry as a whole for the best part of 20 years, and it's been a very problematic area for health economists to deal with. Activity-based funding in aged psychiatry, or funding that's based on clinical outcomes, is again difficult to justify, given that a large proportion of aged psychiatry's work is in people for whom the natural history of their disease is of chronic degeneration and deterioration regardless of what is done. I'm not convinced that activity-based funding is the answer, in short. Certainly for inpatient services, it would probably be a retrograde step. Activity-based funding, when applied to inpatient aged psychiatry services, would mean there's a perverse incentive for inpatient services to keep their beds constantly full. To have an empty bed would be seen as a lost opportunity to generate revenue. The current basis on which beds are funded in Victoria, at least, is block funding. So money is set aside on a daily bed rate regardless of whether or not that bed is full or not. And in services where I've worked, that has allowed me to keep beds available for emergency admissions that might otherwise land up in the emergency department or languish in the acute hospital setting. So I think there's actual disadvantages to activity-based funding, at least in the inpatient setting. I think it's problematic in the outpatient setting as well.
You described in your evidence the increased funding for the older person's mental health services at the severe end of mental health issues. What would that mean? What would the increased funding that you speak of, and the focus of that increased funding, deal with those that you describe in the statement as the missing middle? So those that don't reach that severe end but are too complex for the general practitioner?
Sure. The reason aged psychiatry services currently restrict themselves to that pointy end, and previous witnesses have alluded to having to be either overtly psychotic or overtly suicidal to get service, is because the funding is constrained to the extent that resources have to be rationed. So you have a choice when you're running an aged psychiatry service as to who you provide service to enable a maintenance of capacity in your service to respond to it. If you have 10 staff and you consider a reasonable caseload for them to be 15 or 16 patients, that means that the number of people you can provide service to at any one time is 150 or 160. We tend to triage in that setting based on risk, so that the people at the pointy end with the more severe illnesses are the ones to get services. If funding were to be ring-fenced, even at the current levels at which state and territory governments provide it to health networks, aged psychiatry services would be able to broaden their inclusion criteria and treat people with illness of lesser severity than what they're currently able to do. So the current restriction of service to the pointy end, as it's been put, is a consequence of limited resources. I think if more funding was available, the availability of services would flow on to patients who would otherwise have been prioritised lower down the tree of need.
Commissioner, I'm mindful of the time. Would this be a convenient time to break the lunch and adjourn?
Yes, let's check the time.
2 o'clock. Yes.
All right, we'll adjourn now till 2 p.m.
The Royal Commission is adjourned until 2 p.m.
The Royal Commission is now in session.
So,
Professor, we've asked you to consider some evidence that was received by the Commissioners on 10 December of last year at the Canberra hearing, ahead of today. And in taking you to that evidence, I'll ask the operator to please display document ID RCB stop 999 stop 0370 stop 0001. Do you see on your screen before you a portion of transcript which is highlighted?
I do.
And is that the portion of transcript that you've been provided by the Royal Commission to consider ahead of your evidence today?
I don't recall seeing this, I'm afraid. But if you give me a minute to digest it.
Certainly.
Okay, please proceed.
Thank you, Professor. What that portion of transcript sets out is evidence received by the Commissioners on that date that was given by Dr. Carolyn Hullock, who's the Chair of Geriatric Emergency Medicine at the Australian College of Emergency Medicine. And I will let the transcript speak for itself, but the evidence pertains to meaningful partnerships and how they're facilitated within her work in geriatric emergency medicine and the older person's mental health unit.
Yes, my apologies, Council. I do recall reading this now.
Having had the opportunity to refresh yourself as to that portion of the Commission's evidence, could I ask you to respond to the observations that Dr. Hullock makes in that transcript?
I would agree with them. There's a lot of fragmentation, not only between states, but within states, as to who takes responsibility for which service. In some states, for example, or some parts of some states, it's not aged psychiatry who, within the public system, goes out to respond to BPSD, but it's geriatric medicine. And the providers themselves, aged care providers, aren't really to know who provides what in any given part of any given state or territory because there's no national consistency. Part of the problem, I think, is that the Commonwealth division, the primary health networks, bear no relation to the catchment areas of the various state-run health services. So any given PHN might incorporate 2, 3 or perhaps 4 public hospital catchment areas, and depending on which part of the PHN you're in, the particular aged psychiatry service may or may not respond to BPSD. The responsibility may lie with geriatric medicine, or indeed there may be no specific outreach service assigned to that responsibility. So I think this statement speaks to a lack of similarity and predictability within state and territory health services.
How could consistency be achieved?
I think it has to come at the state level. It's pretty hard for states and territories to align, but then again, a provider tends to be located within a particular state or territory rather than multiple. So if there were some state-based consistency regarding whose responsibility it is to respond to which client group, that would help. I suspect the funding issues that I alluded to prior to lunch may be part of the reason why this dichotomy occurs. In some health networks, geriatric medicine may receive the lion's share of the funding. In other jurisdictions, it may be apportioned to aged psychiatry for those outreach services. But again, if funds that were mandated for aged psychiatry services at the state and territory level were ring-fenced at the health network level, that may help address problems like this.
Do you consider that the separating out of funding, where the Commonwealth funds dementia service and the state is funding the older person's mental health unit, makes sense when there is the degree of overlap between those mental health issues and those behavioural psychological symptoms of dementia, and the overlap that you described between those two earlier on in your evidence?
Absolutely. Certainly it's been my experience in aged persons' mental health that if another provider can be identified who can do the work, it's common practice for the triage of aged persons' mental health to direct the referrer to that other service rather than do it themselves. If they perceive that a hospital admission may be required, the response might be somewhat different. There are complexities in people who have pre-existing mental illness. There are complexities in people who've had acquired brain injuries and strokes, all of whom may develop degrees of behavioural disturbance, and none of which might necessarily be best fit on prima facie basis for either mental health services or dementia services. If you've had somebody with a head injury, for example, who's in residential care and has disinhibited or aggressive behaviours, aged person's mental health might reasonably take the view that that's not a mental illness, it's an organic brain syndrome following a head injury. And dementia support services may equally take the view that their specialist services and behavioural interventions that are targeted specifically towards the needs of people with dementia may well not be applicable to that client group either. So large groups of people with psychiatric comorbidities, where there's some debate about whether any given behaviour reflects dementia or the comorbidity, may often fall between the gaps. Younger people with head injuries and people with strokes and other static neurological conditions but with behavioural problems are also another group who find themselves in no man's land of service provision. And it's very hard, even if you consider just the division between dementia services and aged psychiatry services, for a provider to know which service might be appropriate, because the provider can't necessarily answer the question of which condition the behaviour arises from. The result often is that the provider then refers to everybody in the hope that somebody will provide a response. So we get this shotgun referral effect. And in services I've worked in, we've had the experience of turning up to do an assessment at the same time as another clinician from another service has arrived to assess the same patient, having been referred to multiple different services in a shotgun style. So the divisions are further amplified depending which additional groups you bring into consideration. If the differentiation between psychiatry and dementia was not bad enough.
So if I might ask Professor McFarlane, if you were to work through this complexion model of different arrangements, what do you think an ideal arrangement would be like, including the split between the Australian government and the states and territories?
Big question, Commissioner. I think the workload is too much within the dementia space in particular for any one service to be able to do it all. Dementia Support Australia sees in excess of 10,000 cases per year, but in relation to the number of people in residential care who live with dementia, that number is still small. We rely on the availability of other services such as aged psychiatry, such as public hospital geriatric outreach, and private geriatricians and private old age psychiatrists to help share the load, because there's so much work that I don't think one body could feasibly be tasked with doing it all. So, although it's, I think, inevitable that multiple players remain involved, particularly in the dementia space, I think it's entirely reasonable that some of the lower tier BPSD work is directed to DSA rather than taken on by aged persons' mental health. I mentioned earlier that aged persons' mental health would be able to do more and increase their scope if the funding was made available for them to do so. Similarly, private psychiatry could probably do more if we end up training more aged psychiatrists. But the bun fight between state and federal funded services needs to stop, because there's attempts at cost shifting in both directions, and probably some agreement needs to come into force, perhaps via the COAG mechanisms, to reach an agreement between states, territories and Commonwealth about who does what and what the appropriate split of services should be. And then the funding approach needs to be enforced at the level of the health networks.
That sounds highly sensible, if I might say so. Thank you.
Professor McFarlane, what strategies do you employ in your day-to-day professional experience to overcome or to tackle the raft of challenges which you've set out to the Commissioners in evidence today and in your written materials?
I'll speak largely in reference to my current role at Dementia Support Australia, where I'm Head of Clinical Services. We get a number of referrals through our triage system where the question of dementia as the primary cause of the behaviours identified is debatable at best. When our triage workers are unable to clearly identify whether a referral is in scope for us or might be better served by aged persons' mental health services, triage worker will generally discuss that case either with myself or with one of our other specialist doctors around the country. We have around 20 geriatricians and old age psychiatrists who work with the service. And often if a high level of medical input into the triage process is exercised, then a suggestion to redirect a referral where I think, for example, behaviours might be better explained by head injury or chronic schizophrenia to a more appropriate referral, source, that medical opinion will probably carry more weight than simply the triage worker pushing back. And often we can resolve any issues that might arise around jurisdiction by a direct communication between myself and one of my colleagues and the relevant service head, whether that's aged psychiatry or geriatric medicine outreach. So that's how we try and address that. At the level of triage as well, sort of recognise that the shotgun referral is a common phenomenon. So we've introduced as part of our triage process a series of questions designed to identify if another referral has been made to another provider. If a referral has been made and we identify that, we might proactively reach out to that other provider and find out whether they have taken on the case and what their evaluation of the situation is. And then on a service-to-service level, individually resolve who might be best placed to respond to the particular referral. It's been a very difficult process, again, because of the lack of state and territory-wide consistency as to who does what. So really, depending on the region or the PHN within which the referral resides, we have to negotiate agreements at the level of individual health services, individual geriatric psychiatry and geriatric medicine services, which is very onerous and very time-consuming. And we can't do that sort of liaison with everybody due to time and resource constraints, but we do it when required on a case-by-case basis. Would greatly assist if there was some national consistency.
Is that, in your view, a demonstration of what is possible, what is the best practice for referrals within the current system?
Within the current system, if there's any doubt as to whether a referral is more better placed with one provider or another, I think best practice is reaching out to that other provider and having the discussion, particularly if it's a referral that has already been knocked back by that service's triage worker. Because if you get people on triage without the experience and the knowledge to determine what is due to what in terms of people with multiple potential causes for behaviour, it's a very difficult job for the triage worker to resolve. So that high-level discussion between senior clinicians within each service with a degree of collegial goodwill accompanying them, I think is best practice in resolving those triage concerns. It's also best practice for services to collaborate in the management of a case. Certainly in cases where aged psychiatry services have taken on a referral with significant BPSD, for example, at DSA we realise that their ability to provide anything much more than a time-limited service due to service pressures is somewhat constrained. So we will accept referrals from aged psychiatry to provide ongoing behaviour management support in situations where aged psychiatry's resource no longer allows them to do that. We also consider it best practice on discharge of a person from hospital where they may have been admitted with behavioural disturbance or some sort of other psychiatric condition, and try and liaise with the treating team within hospitals to try and determine which service may be better placed to provide the follow-up to a particular case as well. Often we don't find out about those cases, however, until people have left the acute hospital setting. We might receive the discharge summary, which has the recommendation within it to refer to Dementia Support Australia, but on review of the case, we find that person's needs don't reflect dementia behaviour disturbances at all, and then we have to redirect the referral despite the aged care provider having been informed by another health provider that we should become involved. That's frustrating not only for us, but for providers who then make the ongoing referrals. So the ideal of best practice and what has been achieved thus far are two different things, though we are slowly narrowing the gap. We're certainly better prepared to manage that potential conflict now after 4 years of operation than we were when we started.
Recognising that your evidence, and I draw from paragraph 7.3 at stop 0010 of your response to propositions document, recognising your evidence is that aged care providers are not healthcare providers. Sorry, approved providers of residential aged care are not healthcare providers. But recognising that approved providers of residential aged care are providers of lifestyle, of a care setting in which the care recipient is often entirely reliant on that approved provider for their needs to be attended to. What do you say the approved provider should be doing at the access point? What should the gateway be for accessing mental health services in that setting? And how does that relate to the referral issues which you've just described?
Okay. Common practice currently is for the registered nurse or indeed the non-clinical manager of a facility to view a particular circumstance and just make a judgment call, which may or may not be influenced by any clinical background the manager in particular might have as to what's appropriate. Often the detailed medical history of people who land in residential aged care is not well communicated, and a provider might simply see a list of diagnoses and times at which those diagnoses were made. That in itself provides no guidance to the provider whether they have a clinical or non-clinical background about which service might be appropriate. So the shotgun referral is made, or a best guess is made in terms of a referral to a service that the provider thinks is most likely to respond. In truth, general practitioners who are looking after residential aged care residents are constrained by similar shortcomings. They receive a discharge summary from a hospital which relates to past medical history. It lists a number of potential contributors to behaviours. DPs aren't necessarily well equipped on the basis of the information they are given from the hospital or which they receive on admission to aged care settings via the ACFI assessment as to which behaviour reflects which comorbidity as well. So I suspect that the referral practices of GPs are influenced by their past experience about which service will respond at all and what's available in their local area.
What can change now, in your view, in the short term, to grasp these issues?
I think what's achievable in the very short term, arguably at no additional cost, is beefing up the resources of aged psychiatry services. I mentioned in earlier evidence that a lot of what state governments think they are funding aged psychiatrist services to do is not actually passed on to them by the health networks. In my own experience, the decrease in budget can be as high as a third what the government thinks they're funding us for to what we actually receive. If the current monies were directed in their entirety to aged psychiatry service, it stands to reason that they could improve their service response and their scope and their manpower and their reach by 50%. And that's at no increased cost over existing arrangements. It does require the will of state and territory governments to enforce accountability and transparency mechanisms upon that funding, But to me, that's the low-hanging fruit for a very quick win at minimal cost in this situation.
What change do you want to see from approved providers in, I'll rephrase that, is there change open to approved providers to tackle the shotgun referral situation that you've described in the short term?
There is. I mean, any particular provider in any given location will have access to a range of referral options, and they may vary according to the state you're in or whether you're metropolitan, regional, rural or remote. But each provider should have the capacity to identify the services within their local area that exist. And I think that the providers then reaching out to those providers and determining the stated scope of response of those providers is something that's very achievable. It requires providers to be a bit proactive in terms of that reaching out. But if the providers then know who will respond to what and the constraints around that, that will help minimise the shotgun referral, and it will also help minimise disputes because there will be an understanding in place between the provider and the person who's responding to the referral about who does what. So there can be no argument if there's a pre-agreement between provider and each service around who does what. That requires a lot of work from a lot of providers up front, and it requires minimal work ongoing, perhaps, as new services are developed and rolled out. But I think it would be very worthwhile and save a lot of time and effort at the level of triage, at the level of shotgun referrals and tertiary service providers negotiating amongst themselves on a case-by-case basis who does what. So the providers can do that legwork up front now, and those resources can be clarified at the level of the individual provider. GPs can do the same, I would imagine, and I did particularly like the suggestion in the papers provided around accredited aged care general practices, which may enable further expertise to be built up in the general practice sector around who is more appropriate for what service as well in the aged care context.
Commissioner, that concludes the questions that have been asked.
Yes, thank you. Commissioner Briggs, any further questions of Professor McFarlane?
Thank you, Commissioner. I have to say, Associate Professor McFarlane, that I found reading the submissions to us for this hearing quite depressing. What they reflect is there's inadequacy of service provision, inadequacy of dollars, unfair access to services, a shortage of prevention and so on. You've talked a little bit about what we could do in the immediate term to fix this up and the fact that we need more funding in the sector, we need Commonwealth and state activity to deal with the issues, and we need a larger workforce. I suppose I'd like your understanding of how we get to where we should be. And I think what I need in order to understand that is to know where should we be. We can generally rely for our physical health on the availability of services as and when we need them, albeit with some waiting periods for some access. But in this area, I don't get that impression. So can you tell me what the picture should look like and then try and help us understand the steps to get there? Hard question, I know, but please help us.
Okay. The ideal, of course, would be to prevent problems occurring in the first place. And one of the long-term flaws that is applicable to the health system in general, but has specific application in aged care as well, is that our health system is very much geared around treatment of existing problems. It is much cheaper in the long term to invest in prevention, and the same amount of money invested in prevention will save big dollars down the track, not only in terms of acute care services, but also in aged care services. We know from research, for example, that about 20% of cases of dementia can be prevented with appropriate early lifestyle interventions. And if you decrease the number of people who ultimately are going to require services for aged care and dementia-specific behaviour management, that eases the burden on services. There are disincentives in our current political system for getting there, because prevention accounts for a very small percentage of the overall health budget, and governments are not frequently applauded for investing large amounts of money in something that will have a payoff 20 or 30 years down the track beyond the expiry of the electoral cycle. So there are practical and pragmatic and political considerations in getting where we need to be. But we should start with prevention. And it's my own view that the single best thing we could do to improve mental health in older populations, in both a preventative sense and a treatment sense, simply to increase the age pension. Once you address the risk factors for ill health in terms of mental health in old age, the burden of disease drops itself, and older people are subject to greater degrees of economic hardship, social isolation, loneliness, access to transport and public transport, all of which could be addressed by an improvement to the aged care pension. That's probably a discussion for another forum, but that's where I think we need to get to, improving prevention and improving the range of generic supports that we provide to old people, older persons, to prevent them getting into aged care in the first place where these problems are endemic. If you keep people at home and healthy and not suffering from conditions that require entry to aged care, that's a large part of the solution in my book.
And what would a good system look like? Let's think about in 10 years' time. What would we have?
We would have a comprehensive diagnostic network for a start. At the moment, with these complex cases with medical comorbidities and psychiatric comorbidities and dementia, the question of who treats what is a bit of a moot point, because often at the point of referral, services don't know what they're managing in truth, and the necessary precondition to managing something is an adequate assessment of something. So if the arguably 20% of people who reside in aged care who have dementia but haven't received a diagnosis of dementia receive timely access to diagnostic services, so when problems arise, it is known and well documented and part of a transparent and transportable medical history that travels with the patient between home settings, general practice settings, acute hospital settings, subacute settings, rehab settings and aged care settings, then everybody knows what's what because information is well communicated. That's a task for IT systems, which currently don't communicate well with each other. It's a task for hospital discharge systems and communication with general practice, but also the necessary pre-step to managing anything is to get a good diagnostic system in place and to ensure that that diagnosis and the rationale behind it and the diagnostic steps that led to that diagnosis remain with the patient and aren't simply lost or confined to one isolated part of the medical record. Those things I think are achievable within 10 years. We need to get those IT systems talking to each other. We need to get different parts of the health services communicating with each other, a free transfer of patient-related information where it's necessary in the best interests of the individual patient, be communicated freely across all care providers who have an interest in that patient without the what I think are often the unnecessarily intrusive requirements of privacy, preventing good care, where a breach of privacy, a technical breach of privacy is necessary in the interests of a good outcome for the patient, where the patient can't provide consent for the release of the information by virtue of incapacity. I think that such breaches of privacy are probably justified in terms of Good Samaritan work. But there's too many barriers at the moment to good information transfer. But that's where I'd like us to be in 10 years, a good diagnostic and assessment system that's supported by robust information transfer.
And can I ask you one other question associated with that? And that is, who do you see as, for want of a better word, the practitioners operating within this diagnostic system and indeed delivery system?
I think the diagnostic system is very well served by the memory clinic structure. Certainly in Victoria, there's been a network of CADMs, cognitive assessment, dementia and memory service clinics, funded by the state government since about 1996. These are multidisciplinary clinics that have cognitive nurses, social work input. They're often staffed by a multidisciplinary medical mix. There could be neurologists, there could be geriatricians, there could be aged psychiatrists, there could be general practitioners with expertise and interest in dementia. But because there are multiple different causes for cognitive decline, it's great to have access to different medical specialties within those clinics as well. Most of those clinics are funded to a degree by Medicare billings nowadays, I believe. That again, possibly as a result of cost shifting between state and Commonwealth, but the system seems to work. If a national system of memory clinics that mirrors the Victorian model, and I only mention that because it's the one that I'm familiar with, is rolled out, that would be a good beginning, supported by, I know what is a current move towards a national dementia registry as well, which would serve a number of purposes, including facilitating continuity of care. The diagnostic services, of course, because we have patients in residential care with multiple comorbidities, those diagnostic services and the transfer of information really needs to be mirrored at the level of stroke services, acquired brain injury services, psychiatric services, and so forth. But if you accept that most of these services are within existing public hospital infrastructure, if you improve IT and communication systems across the hospital network, you achieve those ends for all conditions, not restricted to dementia and mental health, but also stroke and acquired brain injury and alcohol-related brain injury.
So one last question. If Commissioner Fagoni, I'm sorry, will bear with me. So we then get to the Commonwealth and the states discussing roles and responsibilities. Is it their responsibility to give life to this vision that you imagine, or is this a partnership between government and the key players, or how is this strategy advanced?
I think there needs to be some agreement at the level of COAG as to a national direction that is agreed to. It's probably down to the states and territories to provide IT platforms to the various health networks in their state or territory that can communicate with each other. And in an ideal world, because people move their place of residence from state to state, or a similar nationally compatible information technology data communication process to be put in place so that information can be transferred interstate as well. And I suppose My Health Record is an attempt to do that, but there's an opt-out and the uptake is low. But where the information exists, it currently exists in silos and it needs to be communicated better. So the states need to provide their health networks with uniform IT that talks to each other, and the Commonwealth needs to perhaps wield the stick with the various states and territories to not come up with their own individual solutions, but to provide solutions that are nationally compatible as well. The level of the individual providers, I think once the providers, the aged care providers are provided with national uniform services with a predictable response regardless of where you are, that problem should sort itself out. Very hard for an individual provider to do it at the individual provider level currently. Could argue perhaps that the IT systems that providers use to document resident progress notes might also need to be compatible so that whatever the provider has can be transferred to the hospital when an acute admission occurs with a similar degree of ease. Thank you, Commissioner.
Yeah, we could definitely argue that. We may well do. I think those are all of my questions. Thank you for your perseverance.
Thank you, Commissioner Briggs, and thank you, Professor McFarlane. It's been very helpful. You've assisted us on a number of occasions, and your written and now oral responses have been extraordinarily helpful. So thank you very much indeed.
Thank you for the opportunity, Commissioners.
And you're excused from further attendance. Thank you very much.
Thank you.
Mr. Knowles,
Yes, Mr. Knowles.
Thank you, Commissioners. I now call Professor Sunil Barr, Mr. Mark Silver and Dr. Leanne Beagley.
Associate.
Professor Barr, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Mr. Silver, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Dr. Beagley, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please
I
say
do.
I.
Thank you. Mr. Knowles.
Thank you, Commissioner Gale. Can I start with you, Dr. Beagley? Can you tell the Commissioners your full name?
Leanne Beagley.
Thank you. Professor Barr, can you tell the Commissioners your full name?
Sunil Singh Barr.
Thank you. And Mr. Silver, can you tell the Commissioners your full name?
Mark Silver.
Thank you. Professor Barr, if I can start with you, you have prepared a statement for the Royal Commission with the IFD number RCD.9999.0308.0001 marked on it. It's dated the 19th of March 2020. Do you have a copy of that before you?
I do.
Yes. You have also prepared a response to various draft propositions dated the 19th of May 2020, and that is has been uploaded with a document identification number of RCD.9999.0336.0001. Do you have a copy of that document with you?
Yes.
Thank you. And have you read both of those documents lately?
Yes, I have.
Thank you. And are there any changes that you wish to make to either of those documents?
Yes, there are two changes to the first one.
And can you tell us which of the documents do you require those changes to be made to?
Yes, this is the one with the ID 999-0308-001.
Thank you. And what page is the change that you wish to make the first change?
The first change would be on page 6.
Yes. Yes.
And it's in reference to point number 6.
Yes.
The original statement is they provided residents with 6 sessions. The revised statement should be 20 sessions of CBT over 6 months.
Yes, thank you. And the second change you'd like to make?
Second change is on page 7.
Yes.
In reference to item 7.
Yes.
And in the paragraph, originally, it's reading affordable or people, and it should be affordable for people.
Thank you. And there are no other changes, Professor Barr?
There are no other changes.
And subject to those changes are the contents of your statement as well as your response that you have given, true and correct to the best of your knowledge and belief, and are the opinions held in those documents genuinely held by you on the basis of your expertise?
Yes.
I seek to tender the statement of Professor Barr as well as Professor Barr's response to the draft propositions.
Yes, thank you, Mr. Knowles. On the statement and the response will be Exhibit 17-6.
Thank you. Can I turn to you, Mr. Silver? You have provided a statement to the Royal Commission with document ID RCD.9999.0307.0001, and that was dated the 19th of March 2020. Do you have a copy of your statement before you, Mr. Silver?
Yes, I do.
Thank you. And you've also provided a response to the draft propositions, and that response is dated the 22nd of May 2020, and that has document ID RCD.9999.0336.0005. Do you have a copy of that document with you as well?
Yes, I do.
Thank you, Mr. Silver. And have you read those documents lately?
Yes, I have.
And are there any changes that you wish to make to them?
No.
Thank you. And are the contents of the statement as well as the response true and correct to the best of your knowledge and belief? And are the opinions expressed in those documents genuinely held by you on the basis of your expertise?
Yes, they are.
Thank you. I seem to tender the statement and the response, Commissioners.
They will be Exhibit 17-8.
Dr. Beagley, can I turn to you? You have prepared a statement dated the 10th of July 2020, bearing document ID number RCD.9999.0363.0001. Do you have a copy of your statement with you there?
Yes, I do.
Thank you. And in your statement, you refer to another statement of a colleague of yours, Mr. Harry Lovelock, who is also an employee at Mental Health Australia, dated the 20th of March 2020.
Correct.
And subject to what you say in your statement, you have adopted the contents of Mr. Lovelock's statement.
Yes, I have.
Yes, thank you. So, can I ask you whether you've read both your statement and Mr. Lovelock's statement lately?
Yes, I have.
Thank you. And are there any changes that you wish to make to either of those documents, save for the matters that you've set out in your own statement about the qualifications with which you accept Mr. Lovelock's statement?
No, no further changes.
Thank you. And are the contents of your statement true and correct to the best of your knowledge and belief, and the opinions in that statement genuinely held by you based on your expertise?
Yes, they are.
Thank you, Dr. Beagley. Commissioners, I seek to tender as a bundle Dr. Beagley's statement dated the 10th of July 2020 together with Mr. Lovelock's statement dated the 20th of March 2020.
Yes, well, that will be Exhibit 17-8.
Thank you, Commissioners. Now, Dr. Beagley, you are the Chief Executive Officer of Mental Health Australia.
Yes, I am.
And that's the national non-government peak body representing the Australian mental health sector.
That's correct.
Thank you. And before assuming that role this year, you were the Chief Executive Officer of Western Victoria Primary Health Network from 2017 to 2020.
Yes, I was.
Thank you. And you have otherwise got considerable prior experience in senior mental health roles at the Victorian Department of Health and Human Services as part of your history vocationally.
That's correct.
And you have clinical qualifications in occupational therapy and family therapy.
Yes, I do.
Yes. And you have a Master's in Business Leadership and a PhD in Psychology and Organisational Culture and Performance.
That's correct.
Thank you, Dr. Beagley. And Professor Barr, you are a clinical psychologist and Professor of Psychology at Swinburne University of Technology.
Yes, that's correct.
And you have expertise in clinical geropsychology.
Yes.
And since 2011, With Mr. Silver, you have run the Wellbeing Clinic for Older Adults, Swinburne's mental health outreach service for older adults living in residential aged care.
Yes, that's correct.
Thank you, and I'll come back to the Wellbeing Clinic in a moment. Mr. Silver, you have a master's degree in social work.
That's right.
And over 40 years of experience as a social worker in aged care, disability rehabilitation and psychiatric services.
That's right. That's right.
Yes, thank you. And you're also involved in considerable educational and research work in the field of social work, psychology and counselling.
That's right.
Yes. And with Professor Barr, you established the Wellbeing Clinic for Older Adults in 2011, and you're currently employed as the coordinator for that clinic.
That's right.
Thank you. Well, can I ask you, Mr. Silver, can you briefly describe what the Wellbeing Clinic is and how it works in practice?
Yes, I'd be glad to. Professor Barr and myself established the Wellbeing Clinic during my employment working in a large organisation providing care for older adults, both in the community and in residential care. And we realised that there was not a lot of expertise or services around emotional wellbeing and mental health, especially in residential aged care. And when we got together through a advisory committee on a project that was looking at emotional wellbeing, we realised that there was both a need to provide services for emotional wellbeing within aged care, but also equally a need to train mental health practitioners to enter that space, because there hasn't been a lot of work that had been previously done in order to provide practical experience and training for mental health practitioners. And so we have established that program, which provided initially postgraduate psychology students, but it also extended to counselling and social work students to learn really from the facilities, from the residents and families and staff, how to engage with older adults, but also to learn about ways of training, providing that practical experience. So over the 10 years, we both through research programs, but also through learning from the services and from the residents and family, some of the ways in which we could approach this area, and we've been delivering those programs for 10 years now, and looking at some of the elements that have been useful in providing effective services in that area.
Yes, thank you, Mr. Silver. Professor Barr, this is a service whereby students are placed in residential aged care facilities and provide counselling and other services, get experience and training in the process. That requires them to actually attend at the facility. You've recently introduced a telehealth service. How has that changed things in terms of the scope of provision of service for the Wellbeing Clinic?
Yeah, thank you. Traditionally, the Wellbeing Clinic has been a face-to-face clinic. In fact, we've often told others about stereotypes regarding older adults, and we too have been guilty of that. We never thought that older people living in residential aged care could benefit from telehealth counselling. But due to the COVID-19 restrictions, we've had to switch all of our face-to-face services to telehealth services. And we've been very pleasantly surprised, very pleasantly. Older people in residential care can absolutely interact with counsellors not only by phone, but also through video conferencing. However, it does take the support of the aged care provider, the aged care facility, to try and facilitate those telehealth appointments. We did a very small trial over about a month and a half, and we discovered that about 70% of our attempts to contact and speak with residents were successful. And that exceeded our expectations. We did not believe that older people living in care would be able to make such good use of telehealth, but they've embraced it. And in some cases, they've preferred video conferencing to telephones. So I think we have a lot to learn about how to deliver telehealth in a meaningful and effective way within residential aged care. And I think we've just about started to do that.
Yes. Can you explain to the commissioners, Professor Barr, how the Wellbeing Clinic is actually funded as such at present?
Yeah, at present it's funded through three sources. Firstly, Swinburne University offers a little bit of funding to run the clinic. Secondly, we get funding from research projects. And thirdly, it's really run on the basis of a huge volunteer workforce and in-kind assistance.
Yes. So do you see, how would this work on a wider basis, this sort of model, in circumstances where you are relying on that volunteer base? How do you see it being potentially, is it potentially scalable, and how would you see that happening if it is?
It's absolutely scalable. And not only scalable, it's such a cost-effective way of delivering psychological services to residential aged care for a couple of reasons. One is that trainee psychologists and social workers and counsellors are highly motivated, and in fact, the research shows us that they do exceptionally good work under supervision. And we've done some very basic health economics, and we deliver services 3 times cheaper than you would with registered, fully qualified practitioners. So from an economics perspective, it really does lend itself to being something that the government should look at, fund on an ongoing basis. It's extremely scalable in 2 ways. The first way is through telehealth, obviously, because telehealth brings with it completely a non-reference to geography. You could be in Victoria and offer services to Queensland or vice versa. But secondly, every university around Australia could duplicate this model, and through its own supervision arrangements could foster a workforce that could not only deliver psychological services now, but of course for the future as well. Because one of the big problems, as you've been hearing, is that there is such a lack of people out there who are trained. And so a clinic like this offers 2 things at the same time: a service right now, but also a workforce for the future.
And what sort of professional oversight is there of the undergraduates who are actually performing the services, in terms of the fact that they are not fully qualified, and how are they overseen, and how is quality managed in that respect, Professor Barr?
Yeah, so the governance of these kinds of clinics has to be very, very tight and very strong. The different professional groups have different governance structures built within it. For example, in psychology, we would never send an undergraduate student out to residential care. It would be someone in their postgraduate years of training, but they've already received 4 years of psychology training before we would include them in a program such as this. The supervisors for psychology graduates has to be board approved by the Psychology Board of Australia. In addition, the supervisors who manage the students would meet with the residential aged care facility staff regularly to ensure that not only is the services being provided in a way that's consistent with the profession, but that we're working very, very collaboratively with facility staff. So there are multiple levels of oversight and supervision, not only individually, but also with care staff, and as well through group supervision. In fact, we found that group supervision offers a very, very interesting way of not only learning from each other about what works, but also hearing what people are doing in their different clinics and different professional groups, and learning from each other, whether it's social workers, counsellors, or psychologists.
Thank you, Professor Barr. Now, can I move on from the Wellbeing Clinic and just for the moment at least, and ask you, Dr. Beagley, we've received a response from Mr. Silver and Professor Barr in respect of the draft propositions. Can I ask you, in general terms at the moment at least, what's the position of Mental Health Australia in respect of the draft propositions on mental health M1 through to M8?
Thank you. Yes, well, Mental Health Australia supports all of the propositions in relation to mental health, with a couple of clarifications. Is that
yes,
Mr. Knowles? So,
yes.
In terms of proposition M3, the increasing funding for psychologists providing psychological services, we would be recommending that this proposition recognise the range of other allied health providers who provide services through the MBS mental health plans. So that includes occupational therapists and social workers, as well as psychologists.
Yes.
So that would mean that it would be complementary to the other propositions to increase allied health access. And in relation to proposition M8, which was a proposition that the government inquire into the potential contribution of mental health peer workforce in addressing access to mental health services in aged care. We did provide the team with a suggested rephrasing of point 2 to more accurately reflect the role of mental health peer workers, such as perhaps that consideration should be given to increasing the role of mental health peer workforce in providing trained psychosocial and mental health supports to people receiving aged care.
Thank you, Dr. Beagley. Can I just ask you, Mr. Silver, and you, Professor Barr, for your views on those particular qualifications to the draft propositions. In terms of draft proposition M3, which I might bring up on the screen for you, it's in General Tender Bundle Document 28, and it's at page 0005. I'll read out the number. It's RCD.9999.0343.0002. Pardon me. That should be coming up now. So at the page 0005, there's the bold text relating to proposition M3. And you'll see that there towards the bottom of the screen that should be before you now. So that's the proposition which goes to increasing access that is funded through the MBS for psychologists to provide services pursuant to a mental health treatment plan to those living in residential aged care. And the services are up to 15 services in a 6-month period and benefits commensurate with the National Schedule of Recommended Fees as promulgated by the Australian Psychological Society. So Professor Barr and Mr. Silver, you both heard Dr. Beagley say that this should not just apply in terms of mental health treatment plans to psychologists, but to other allied mental health professionals. What's your view on that? If I can start with you, Mr. Silver.
Yes, I'd concur that the basically the services extend to Medicare-approved providers, which include other mental health professionals, and I think it needs to be highlighted that they are also able to provide those services, and I think that should be extended to them. And also, I think the number of sessions has increased, and I think that's also been suggested. And I think it's also recognises the nature of the issues the complex issues that people in residential aged care have, and that needs to be looked at. The only proviso, and there may be an opportunity to talk about this at another time, is that apart from the episodic nature of the mental health provisions, there also, I think, needs to be a recognition that there are fundamental and ongoing needs that people in residential care have that also need to be addressed and thought about in a different way. And I think that's something else that I would strongly comment on, that the whole process of entering residential aged care brings with it a lot of issues, not only for residents, but also for families and staff. And I think that those things need to be highlighted, and I may expand on that at another time, but
Yes.
that's something that I think is kind of within the nature of this particular proposition that has to be considered.
Yes, thank you, Mr. Silver. And I will take you all to the draft proposition A5, which sets up a funding mechanism on the basis of these two different kinds of care that you have alluded to just then. Professor Barr, do you have a view on draft proposition M3 and its present confinement to psychologists?
Well, firstly, this is what we've been waiting for so many years, for Medicare rebated services to be extended to people living in residential aged care facilities. So all people, right, living in Australia should have access to the same rebates from Medicare for mental health services. I think the same rules generally should apply. If someone living in the community can access an OT or a social worker through Medicare, that should be the same for people living in residential aged care. And so I have absolutely no problems at all in saying that we absolutely concur that the Medicare rebate should be open to anyone who is Medicare approved to provide psychological services, mental health services. It should not only be confined to psychologists for two reasons. One is that different professional groups have different skill sets, and we need to learn from each other. And so OTs and social workers and mental health nurses bring different perspectives, and their perspectives might be more relevant, if you like, for the aged care resident. Secondly, I fear that there aren't enough trained psychologists out there if the funding was reserved only for psychologists. And as you've referenced earlier, at Swinburne University at least, we're trying to fix that gap by preparing workforce people. At the moment, simply aren't enough of us if we were the only group allowed to benefit from the Medicare in this case.
Yes, thank you. In a similar vein, if I can take you back to the propositions before this one, proposition M2, which is at page 4 of that, 0004 of that same document, and that relates to MBS funding for a comprehensive mental health assessment upon entry into residential aged care, and then a review of that within a certain period of regularity after that. Now, I don't wish to go over the broad idea of that because you are, as I understand it, all in agreement with that. But at the moment, as it's framed, it refers to psychiatrists performing that task of assessment and review. Professor Barr, do you have a view about that particular framing of the proposition?
Yes, I don't think there are enough psychiatrists either to be performing that role. So my view is similar to what I said earlier, that role should be widened to anyone who is in a position to perform a review like that. Currently in the community, most of those reviews are conducted by general practitioners, and I would suggest that be extended in this case as well to that group.
Yes, thank you. Dr. Beagley, do you have a view on this particular proposition yourself, in particular in terms of what Professor Barr has just said?
Yes, I support Professor Barr. I would also add, however, that there is a strong association between physical health and mental well-being, particularly with the older people. And so the role that GPs can play in an integrated assessment is really important as well. And so I would just add that as further for consideration.
Yes. Now these items relate to residential aged care. Can I ask you, Dr. Beagley, what your views are about whether or not they should be extended into aged care in the community?
Well, I guess I would just endorse the advice that we've already provided from Mental Health Australia, really, that people in residential aged care settings should have the same access to mental health services as people in the community, and that people who are living in the community who are elderly already have access to mental health services through the MBS plans. I guess you're talking specifically about access to a psychiatrist for a comprehensive mental health assessment, which can be triggered by a GP currently.
Yes, I guess in some respects, in terms of draft proposition M3, it would provide people in residential aged care with more funded access to psychological and other services than is available to people in the community. Do you think that that is appropriate, or do you think it should extend to aged care recipients in the community? And if so, is it a particular sector or segment of those aged care recipients in the community, or do you have a view about whether it should extend beyond residential aged care recipients?
I haven't come to a view about that, Mr. Knowles.
Yes. What about you, Mr. Silver? Do you have a view on that particular point, whether this should extend more broadly beyond residential aged care?
I think there needs to be, as has been recognised, a consistency between community and residential, and that transition point. And I think the main point really is the implementation of the plans as well. The assessments need to be done in conjunction with the ability to actually provide a program that's useful. And I think at the moment there needs to be also that balance between health and mental health that has to happen. And I think that extending has been suggested to that assessment to a much broader perspective where physical and mental health can be assessed together, can be extended to GPs as well. I think it's something that should be considered together.
Yes. At this point, you've been giving evidence about the Medicare benefits schedule funding for mental health services. Dr. Beagley, you, as we heard earlier, were the Chief Executive Officer of Primary Health Network for 3 years, and during that time the Australian government allocated $82.5 million to 31 primary health networks over 4 years to deliver mental health services for people in residential aged care. So by my maths, that averages out perhaps at about $665,000 per annum for each PHN if it was equal, and it wasn't. But was the funding that was allocated to your primary health network sufficient, in your experience, to deliver proper mental health services to people living in residential aged care across the whole primary health network? The answer to that, Mr. Knowles, is yet to be
fully evaluated, really. There's an evaluation underway in the primary health network that was triggered before I moved on, to identify the impact of both that schedule of funding, but also the broader psychological treatment services funding that was being delivered through the primary health network commissioning program. So the initial work that was undertaken when the funding was first received and initiated in late 2018 was to raise awareness of within residential aged care settings of the mental health issues and the needs of people in their care, and then building the capability of the staff and their links with the GPs in order to trigger engagement into that program. And that took some time, early engagement with the aged care providers to help them understand and access services. So your question was, is it sufficient? And I can't answer that question yet. And the evaluation for the program that we initiated in the Western Victorian PHN is due for delivery at the end of the year in December.
So am I right in understanding you to say that what was provided was a program by which people could be made aware of pre-existing services, or were actually new services provided?
No, it was new services provided. Sorry, Mr. Knowles. It was new services provided into the aged residential setting, utilising existing commissioned psychological treatment services that were being provided already in the community, but bringing them and drawing them in to the residential aged care settings. But what was required initially was an orientation, induction and consciousness raising program of work, and so that the aged residential care providers were more attuned than they might otherwise have been to the needs of the residents.
Yes. And are you aware that the services couldn't, under the terms of the program, actually extend to services for family members and carers and the actual staff in the residential aged care facility?
Yes.
Yes. Or nor could they extend to people receiving aged care in the community. It was restricted to residential aged care.
Those particular services were targeted to residential aged care, but there were already existing programs under our psychological therapy services for people living in the community, and GPs were in a position to refer and access those services for their patients as needed, regardless of their age.
Yes. In terms of that particular primary health network program, though, do you see those two matters that I've just referred to as limitations on that program and its coverage and scope?
Well, I would approach the question in a different way, if you don't mind. I would be wanting to underline that the needs of carers for people and partners and family members of people with mental ill health and also of older people are really important matters for early intervention and prevention. And access to those kind of support services are critical, whether someone is living in the community or in a residential aged care setting. And so those services are important. And I think PHNs, as with other Commonwealth funded programs, are restricted by the scope of the policy and funding requirements that go with the programs that are funded into them for commissioning.
Yes.
Might I ask, one of the things that was troubling me as I was reading the submissions was what are the sorts of things that you envisage for that carer, that family group, to link them in and through these processes or provide support to them, Dr. Beagle?
Thank you, Commissioner. The research tells us that that people who are in a caring role are 40% more likely to struggle with their own mental and ill health as a result of their caring role. And so there is much work to do in understanding and providing support to them. And and that would be, I would understand that to be on a scale from understanding the impact of transitions into an aged residential setting, for example, or the natural impact of some of the changes and physical health changes that someone might be going through. So just under psychoeducation, if you like, around the impact of what they might be seeing in their loved one and what some of those challenges might be, but also access themselves to support, which is sometimes quite hard to ask for when they're worrying about the person, their loved one, or the person that they're caring for. And they also might have their own physical challenges and their own health challenges in amongst the challenges that are faced by their loved ones. So there's a range of issues, I think, that you're raising there and are worthy of great investigation.
And for the older person who is assessed as requiring aged care, there's also a strong flavour that families and carers should be involved in the whole process of supporting that person. Do you, Dr. Begley, or one of our other panel members want to take Commissioner Pagoni through how that might be built into this multidisciplinary team approach?
But perhaps
Please.
I'll start and then hand over to my colleagues there. But I guess the most important underlying message that Mental Health Australia would want to convey is the need for a person themselves to drive their care, and that they are at the centre of their own care. And part of that is, of course, who's around them and who they want to be involved in their own care. And so just starting with that, the person in the centre is absolutely critical. But we would not want to imply that doesn't mean that carers and families ought not to be also in the centre as part of planning and thinking through how to manage difficult issues. And the particular concern, I guess, that we would be wanting to convey is just that that often in the planning of care for an individual, the needs of the families and the carers are not fully understood, sometimes are not investigated and not included in the conversations. And they're critical both for the health and well-being and support and connection and social supports, but also for the carers themselves and their capacity to do the caring role. Perhaps I'll stop there.
If I could add, our experience in involving families, they're very much an integral part of the process, and not only in the community but in the transition process, and also their caring doesn't stop once someone enters residential aged care, but the services often do. And this is where I think we've learnt to recognise families as both resources in terms of being involved in the whole process of understanding someone who's gone into care and being involved in the whole planning of how to assist them with building identity and building their connections and building a sense of meaning, all those things, but also as clients in their own right as they go through the particular issues that they face in terms of being still involved in their care and wondering how they can be, especially in areas of where there's deterioration in cognition and behaviour and other issues. So fundamentally, we've taken the approach, a very systemic approach, where we've involved families both in individual ways, but also increasingly in family support programs where people have been learning from each other as families and giving support to each other. And I think that's very often is very, very important to consider, and I think we very much would like that to continue, that kind of systemic approach where we involving families are obviously also staff, and I think that's something that has to be integral in services that are provided, both in the prevention area and the early intervention area, as well as in terms of further along the track as dealing with more severe issues. Mm-hmm.
Professor Barr, I wouldn't want you to feel left out. If you wanted to add anything very briefly in view of the time.
Very kind. I'd like to concur with both Mark and Liam. I think what we often forget is that the families are still very integral to the resident's life when they move in. We have a stereotype or impression that as soon as the resident moves into care, the families are somehow disconnected. And I think that's how many families feel. You know, they feel that even though they've been caring for their loved ones for years and years prior to entry into care, as soon as the older person enters into residential care, the family's views, family's preferences, their knowledge is not really valued. And just like Mark said, I think what we've seen over the past 10 years, involving family along with the resident in the care, there's just been so much benefit, not only for the resident, but also for the families who now feel included and who now have a voice.
Yes. Can I take you to a further proposition that's put forward, and it ties in with the sort of questioning that you just had from Commissioner Briggs, and it's draft allied health proposition, which is RCD.9999.0343.0019, and at pages 0020 to 21, there is a bold proposition A5 table, and this ties in with what I think you were saying earlier, Mr. Silver, about the role of others in the care of people on entry into residential aged care and continuing in terms of their ongoing and frequent mental health needs. So what role do you see in terms of allied mental health professions in terms of that ongoing and frequent needs, and drawing in on what you said about involving family members as well?
Yes, thanks for asking that. I think that is a really important factor to consider in terms of the role that providers themselves have in providing a full multidisciplinary approach. And I would include social work as well, and mental health within that allied health as well. And it's not only just frequent and ongoing, but it's actually fundamental and essential, I would say, because if one considers the process of when someone comes in, all the changes that are involved in that really need support. And that's the crux of intervention that's needed, that early intervention when someone actually is in the process of moving into residential aged care. That support needs to be provided. And rehabilitation doesn't actually stop when someone leaves a rehabilitation centre necessarily. It needs to be continued. And on most, if not all, rehabilitation teams, there's a full multidisciplinary approach. And I think that has to be one of the fundamentals that we look at, providing a service that embodies the allied health team, which should broaden mental health as well, because it will complement any episodic type of extra services that might be needed at particular times for people that enter more severe needs or enter a time when the Medicare type of services are accessed. So I would support the idea, I think, strongly of providing those funding at the facility level. It also would provide a responsibility for facilities to take an active role in developing an emotional wellbeing and mental health program within the facility, because at the moment that's one thing that is missing. There's a lot of emphasis, and quite rightly, on the physical side, on the health and social and recreational well-being, but not so much on the emotional well-being. And to have someone who can take that responsibility on to develop all those aspects that are fundamental in terms of community connections, identity building, providing some sort of advocacy services as well as coordinating some supportive for families and staff with an emphasis on emotional well-being, is something that I think would take on that role of for the actual provider, the facility, to actually take that role on. And even though there may not be sufficient trained people, as we alluded to take on those roles, it would be a start. Otherwise, unless there's a start to provide those roles, there won't be training programs that are needed to fulfill those roles. So I see that as a really important factor in really developing those kind of services in the future.
Yes. Professor Barr, that said by Mr. Silver, do you see this division between a funding mechanism that goes directly to the aged care provider to provide for ongoing, frequent and everyday mental health and wellbeing services on the one hand, and then in terms of infrequent or episodic matters, perhaps in relation to particular psychological services, that would be dealt with through different funding mechanisms on referral by GPs? Do you see that funding division that's referred to in Proposition A5 as something that you would support, or do you have a comment on it otherwise?
Sure, I definitely support it, but there are a couple of comments. One is that there's something about the language that I think we'll need to reflect upon. For example, episodic and infrequent brings up the idea that maybe someone might not need those services very frequently. In fact, what we know is that more than 50% of people living in aged care facilities have high levels of depression, anxiety, and so on. So we might find that those services that are brought in are actually more frequent than we thought. And to have any kind of cap on it, for example, there's a reference in the document to a cap of maybe monthly psychology services, I think would be completely unrealistic. In fact, I think what we'll see is that there'll be a division between fundamental ongoing services and more specialized services. And we might need to think about the language that we adopt to refer to these two sections. I think that by providing funding to facilities, you will have an embedded allied health service, which I think everyone agrees is a good idea, where psychologists, social workers, OTs, podiatry, they can work hand in hand together in a team environment. I think that is a fundamental positive aspect of the proposal. I think that what's also positive is to have an MBS funded service that can be brought in as needed. But we might want to think about that as a more specialized a service that meets the needs of residents, but not to label it as infrequent or episodic, because we might see that those services are needed more frequently than we anticipate.
Yes. Thank you. And Dr. Beagley, can I ask for your comments arising out of what has already been said, and more particularly in respect of Proposition A5, the position of Mental Health Australia on that?
Thank you, and sorry about the spotlight and the sunshine in Canberra.
No problem at all.
So I guess I would add, so I endorse what my colleagues have said, and certainly the idea of infrequent or episodic rather than clinically driven is probably something I would want to underline from Professor Barr's comments there. I guess I would only also want to add that these additional funding mechanisms would need to at the same time sit on an increased knowledge base of all of the staff. So I see there needing to be a real improvement across the board in the capacities of primary care staff in those settings and aged residential care staff in those settings in understanding and recognising the signs of mental ill health, and so that they are able to identify and refer, but also so that they understand some of the key aspects of well-being and supporting well-being in terms of the social connections, the core of maintaining a sense of identity that residential so residents would be struggling with, supporting coping strategies, the impacts of their physical illness on their mental health, reducing their isolation, all of those social factors, I guess, which are part of delivering a well-being model. And for me, that's the basis and the foundation before you start to add the specialist services on top of that. There's a real need for understanding of the extent of mental ill health, according to the research that we know in people who are living in residential aged care.
Thank you, Dr. Begley. I just have one last question for each of you, and that is, are there other systemic changes you consider necessary to improve access to mental health services in aged care that we have not yet discussed today, or are not otherwise the subject of your written statements that you'd like to inform the commissioners of? Can I start with you, Dr. Begley?
No, nothing further. Thank you.
Yes. Professor Barr, is there anything you'd wish to add in terms of what you see as being necessary to improve access to mental health services in aged care at a systemic level?
Yeah, we've thought about this a lot, and it boils down to three things. Firstly, there needs to be greater funding to provide access, and we've talked a lot about that. And what Dr. Begley just referred to earlier is the second pillar, which is to provide training to aged care staff so they can identify residents who might need a bit of help and to provide some mental health services themselves. And thirdly, we need more training of specialist professionals such as psychologists and social workers who are trained in clinical geropsychology, so that we can start to think and reflect very creatively about what kind of adaptations are required to evidence-based practices to make them more relevant for aged care residents. So I would argue those three pillars are fundamental: funding, training, and availability of specialised professionals.
Thank you, Professor Barr. And Mr. Silver, can I end with you in terms of anything that you'd like to say in respect of systemic changes you consider necessary to improve access to mental health services for aged care recipients?
Well, thank you for the opportunity, and I bear the humbleness really of emphasising the need to hear the voices of people with in residential aged care, and also older adults and their families and staff. I think that has to be at the forefront of any evidence that we hear, and I have brought with me the stories of people who have been in contact with me over the years. I think there needs to be a recognition that mental health is equal in importance to physical health and social and recreational health, and I think that's something that hasn't been reflected in terms of the policies and the actual way that we view funding. And I support any need, any basically requests to improve and increase funding. I think there needs to be, as I alluded to before, some type of appointment of a key person at a facility level to take responsibility for emotional well-being and mental health. And I think that would be a great start in terms of providing some policy leadership, coordination, and taking that in hand. I think that's very, very important. There also needs to be a fundamental understanding of the environmental way that we view care of our elderly, and I think the way that our environment and structure, and we have to commend the Commission for looking at innovative ways of basically organising aged care in different ways and learning from different models around the world. I think that's very, very important. And also providing some sense of comprehensive services between community and residential. The importance of the transition phase, the linking between health, hospital and community, I think that's very, very important. And the importance, as we've emphasised, of multidisciplinary teams and the holistic approach that entails, and trying to find more creative ways of building into our strategy those teams working together as they do. So I think that's something that is fundamentally important to add.
Thank you, Mr. Silver. I misspoke a moment ago. There's one last thing I wanted to ask you and Professor Barr, and that relates to primary health networks. I did ask Dr. Beagley a series of questions about primary health networks. Have either of you had direct experience with primary health networks yourself in terms of the program to deliver mental health services into residential aged care?
Yes.
Yes.
Yeah.
And what can you say this from your perspective, Professor Barr? What are your views about the firstly the extent of funding, and secondly what it is directed to? Do you think that the scope within which it is to be used is adequate, and secondly, is the amount of funding adequate so far as you perceive it?
Yeah, the amount of funding is not adequate. What we've learned in speaking to PHNs, not just in Victoria but around Australia, is that funding does not go far enough to allow the PHNs to then commission services to provide psychological care to residents. It's fair to say, just like Dr. Leanne said earlier, that we're still at the early days. There's not a lot of evidence that's coming out from the PHN services about the outcomes connected with the program. So we don't even know if residents are benefiting from the psychological services. I think that over time we'll learn more about that, and that will be quite instructive. It will tell us whether the scope is too limited, in fact, because at the moment the funding is really directed at the clinician working directly with the resident. There is no real scope for the clinician to work with professional carers or for families, or to involve them in any meaningful way in the care. In fact, what we're learning is that as clinicians do more of that, they're finding their time extremely stretched, and they're finding that they're not keeping up with their key performance indicators, because on the paper, it shows that they're having very few sessions with the resident, but in fact, they're having so many collaborative discussions that are not being counted. I think that's going to be an issue that will emerge as we get more data from this very young program.
Thank you, Professor Barr. And Mr. Silver, I see you nodding. Do you share those views that Professor Barr has just expressed about the Primary Health Network program in this area?
Yes, I concur. Yeah, absolutely concur with that. And I think they have their place. And I think it's to be commended that there's been a start in providing those services, and it's also a strong learning area in terms of expanding the services to families and staff, and also to areas of mental health where cognition also is a limiting factor. So I think they're learning as well to incorporate those areas. Also, the use of groups, and we haven't talked much about that, and that's been a fundamental area as well. That's been very, very important to learn from. As well, as well as using students. And I think we've had some contact with the PHN provider where students have also been fundamental in the provision of services, and I think that is also an area where it can be increased. And as models appear, I think we're going to learn a lot more from this particular way of integrating those services within the facilities, within staff, involved in staff education, involved with family support, which are very, very crucial. And I think we need to very much learn from that. And increased funding is I think, been emphasised throughout the whole process. That's very, very, very important to do. And so I think that's really a very important factor in terms of recognising that PHNs provide one element within the step care model of care, but we need to also build up all the other services as well. Yeah.
Thank you, Mr. Silver. Thank you also, Dr. Beagley and Professor Barr. I don't have any further questions.
Thanks. Thank you, Mr. Noel. Commissioner Briggs, any further questions? Yeah.
More a comment and an invitation. The opportunities to do good in this area are enormous, and I think we've just started to unpack that today. Something that we commissioners are thinking about is the broader question of joy. And we're especially interested in ways that the wider community can engage with and support older people so that those issues of identity, well-being and so on are embraced by all. So my invitation to you is to come back to us in the quite near future with suggestions about the way we can advance consideration of those issues, please. Thank you.
Good, thank you. Well, Dr. Beagley, Professor Barr and Mr. Silver, thank you very much for the efforts that you've put into assisting us in our inquiries. The written material has been very helpful, as have your answers to this and all of the hard work that I know has gone on before, and now some hard work that's come on to come in the future in response to the invitation that Commissioner Briggs has just given you. So thank you very, very much, and it's been very helpful.
Thank you indeed.
Thank you very much.
I need formally to excuse each of you, so for further attendance. Thank you.
Thank you.
Ms. Hill will call the next witness.
Yes, Commissioner.
I call Associate Professor Janet Wallace.
Associate.
Do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
Yes, well, no, you've said I do, but you're muted, so we need to demute you, I'm afraid.
I do.
Thank you. Ms. Hill?
Good afternoon, Associate Professor Wallace.
Good afternoon.
Could I please ask you to state your full name?
Yes, Dr. Janet Patricia Wallace.
I might get you to repeat yourself. We appear to have slightly softer audio in our hearing room. You see if we can get that right.
Janet Patricia Wallace.
Thank you. Associate Professor Wallace, could I ask you to please describe your professional background and experience to the Commissioners?
Sure. I'm the Associate Professor in Oral Health at the University of Newcastle. I'm a registered oral health therapist, and I'm the Architect and Chief Investigator for the Preventive Oral Health Program known as Senior Smiles. I've been working in this area since 2009, and initially in student education, but later developing a preventive oral health program specifically for residents in aged care facilities.
And you prepared a statement which you've signed and dated 16 March 2020?
Yeah.
And you've got a copy of that statement in front of you?
I do.
I'll just ask the operator to bring up document ID RCD stock 9999 stock 0303 stock 0001. Do you see a copy of your statement on the screen in front of you as well?
Yes, I do.
Are there any changes you'd seek to make to that statement?
No, none.
And are the contents of that statement true and correct?
Yes, they are.
In addition to that statement, Associate Professor, you've also prepared a document which is a response to the draft propositions insofar as they relate to oral health.
Yes, I have.
And have you got a copy of that response document in front of you?
Yes, I do.
And I'll ask the operator in the hearing room to call up RCD stock 9999 stock 0317 stock 0001. Do you see a copy of that response document on the monitor in front of you as well?
Yes.
Commissioner, I seek to tender the statement of Associate Professor Wallace along with Associate Professor Wallace's response to draft propositions as a bundle.
Yes, the two will be Exhibit 17-9.
You referred to your development of a student placement at residential aged care facilities for oral health students that are senior smiles. Could I ask you to describe how Senior Smiles came to be and what it is in a nutshell?
Yes, I joined the University of Newcastle in 2008 to develop the placement program for primary and dental hygiene.
I might just stop you there, Associate Professor. We're just having some trouble hearing you. I'll just pause to see if there's anything that can be done from our hearing room, but it might be a case of moving slightly closer to the microphone.
Sure.
If you can speak a bit closer to the microphone, we'll see how that goes. And I'll keep an eye on Commissioner Briggs to see how it's going from where Commissioner Briggs is.
Sure.
So returning to the question, a snapshot of Senior Smiles.
Sure. I joined the University of Newcastle in 2009 to set up a student placement program for our final year dental hygiene. We knew that moving forward there would be for our elderly with our growing ageing population.
I'll just interrupt you, I'm afraid. We're having a difficulty with the audio. I'll pause again to see whether I can determine if there's a solution to it. I'm advised we should give it another go.
Give it another
go. Repeat the question or happy to proceed?
No, I'm fine with the question. Thank you. So I joined the University of Newcastle in 2009 to set up a student placement program in aged care facilities.
I'm afraid that the connection is just dropping in and out.
I tell you what we might do, Dr. Wallace, if you're agreeable, we might adjourn for 5 minutes That way, people can see whether they can come up with the solution to the problem without the embarrassment of everybody looking at them.
Certainly.
If we can't, we will go to a plan B. So you just stay where you are if you don't mind. In the meantime, we will formally adjourn for 5 minutes. So we'll drop the link to the public.
Thank you.
The Royal Commission is now adjourned until 3:55 p.m. Royal Commission is now in session.
Yes, Mr.
Associate Professor Wallace, I won't say this is take 2 because I suspect we might be up to take 3 or 4, but fingers crossed for a smoother run this time.
Thank you.
Now, at the risk of repeating myself, I was asking you before we paused there to describe the work of Senior Smiles. Could I ask you to resume in your answer there for the Commissioners, please?
Certainly. I joined the University of Newcastle in 2009 to set up a student placement program for our final year dental hygiene students on the New South Wales Central Coast, because we knew that our population was ageing, and we knew that oral health probably would be needing some extra assistance in that environment. I started developing a student placement program. That program was attached to research over a period of 5 years, and although the placement initially was set up for a learning experience for the students, while the students were in place, we discovered that there was a lack of any sort of oral health care within the aged care facilities. And after that research was completed, I then went about addressing some of the issues that the students had brought to our attention and designed the Senior Smiles program. So the Senior Smiles program is translational research based on those previous years of the student research, and it places a qualified oral health practitioner, an oral health therapist or a dental hygienist into aged care facilities to provide education for the residents and for the staff, to conduct oral health risk assessments, to develop oral health care plans for the residents, and also to establish referral pathways to local dentists or prosthetists for the residents' oral health needs.
Where does the funding come from to run the Senior Smiles program?
There are two parts of Senior Smiles. The first one was a pilot in 2014. That funding came from the then Medicare local at Erina as a grant which paid for the qualified dental hygienist to work within 5 aged care facilities for 12 months. And then in 2017, I received a philanthropic grant of $540,000 to be used over 3 years from the Eldersley Foundation. That grant pays for practitioners to work in 5 facilities again, and also pays for an operational manager for the Senior Smiles program. So both the pilot program and the current research have been paid for with philanthropic grants.
And those facilities in which the program has run and continues to run, are they at metropolitan or regional or a combination of areas?
So the program that's funded by the philanthropic grant from the Eldersley Foundation runs on the Central Coast in 5 facilities. But since the pilot in 2014, there are also a number of other facilities around the Hunter Valley in New South Wales and in Sydney that actually pay for the Senior Smiles program themselves out of their own funding. So the pilot and the research and the second phase of the research has enabled us to bring that program to attention and to lobby other residential aged care facilities to actually employ qualified oral health practitioners within their facility to deliver the program.
And is it the same program that operates across the different facilities, or do facilities have programs that are Senior Smiles programs that are tailored depending on that facility?
No, the Senior Smiles program is able to be translated or transitioned into any environment. The plan of the program and the delivery of the program is very strategic. We have an orientation program, we have a training program that we provide for all practitioners that go into the facilities. So when they go into the facilities, they're completely trained. They use all the Senior Smiles paperwork, and it's the same model, whether it's in a small facility or a large facility, whether it's in a rural area or a metropolitan area.
In the 7 years since you got Senior Smiles up and running, do you consider that the phase 2 is meeting those needs of the program that you set for it?
Sorry, could you repeat that question, please?
Certainly. How do you evaluate the impact of Senior Smiles? Is it doing the work that you set out for it to do at the beginning?
Okay, so in the pilot, we did pre and post PLARC scores, and also counted how many residents were assessed, how many care plans were developed, and how many residents were referred, where they were referred. Did they go to the dentist or the prosthetist, or did they have to go to an oral surgeon? What was done? Were they referred to the public sector or the private sector? That data is still exactly the same in phase 2. So we collect number of residents who've had a risk assessment, number of residents who've had a care plan developed, number of residents who've been referred to a dentist or any kind of dental practitioner or the dental prosthetist. Have they gone to the public sector for their treatment, or are they being treated in a private dental practice?
And what are the health outcomes that you observed from those residents in facilities where the Senior Smiles program runs?
Okay, so there are many benefits apart from the fact that residents' oral health improves when there's a practitioner in the facility. The residents also have their oral health needs identified in a very timely manner, and the Senior Smiles practitioners advocate for the residents so that they get their treatment when it's needed rather than when it's an emergency. But the Senior Smiles has also had a cost and benefits analysis conducted on it, and there are many other benefits, including improved nutrition, lower risk of pneumonia, decreased GP visits, avoidable admissions to hospital, better quality of life, better denture care, less prescribing costs. So there are many other benefits outside of just the oral health benefits. And there are also social benefits for residents where, because their oral health is maintained at an appropriate level, that their quality of life is better.
Are there aspects of the Senior Smiles program in part or in whole that are scalable to a larger geographic scale, whether it's a state or the states and territories of Australia?
Yes, definitely. The cost and benefits analysis has a rollout MVP that shows that if it was rolled out across New South Wales, the social and health benefits would equate to $143.5 million. So the figures are quite remarkable.
The Senior Smiles model is a focus on an embedded model where, as you've described, all hygienists, all health therapists are engaged by the approved provider for that facility. In the course of your written materials to the Royal Commission, we asked you to consider and to respond to the model that's proposed in Proposition D4, which is to fund services delivered by oral hygienists and dental oral health therapists in residential aged care facilities. Drawing on the model of Senior Smiles where it's embedded in the facility, how does the Senior Smiles model compare with what you understand the Proposition D4 to propose?
So the Senior Smiles model requires the facilities to pay the practitioner directly. Currently, the facilities that are paying for dental hygienists or oral health therapists pay them $45 an hour. So the funding comes from the facility to the practitioner. My experience over the last number of years is that if the funding does not come from the facility and the facility does not have that practitioner on site, then all existing processes, policies, procedures that have previously been set up will disappear when that practitioner is no longer associated on staff within the facility. In the pilot program in 2014, in one of the facilities, we placed a hygienist who was there for 12 months. During that 12 months, that practitioner set up a number of oral health policies, procedures, protocols. At the end of the 12 months, that facility did not take that practitioner on to pay them, and so they didn't have oral health being provided there on site. When we got our second lot of money in 2017, I put a practitioner back into that facility because it was a large facility with a lot of facilities Australia-wide. There wasn't one remaining oral health protocol procedure left that was operational within that facility because the practitioner was no longer on site and other things take priority.
Commissioners, I'm mindful of the time and wary of the delays that we've had. I would expect to be no more than 10 to 15 minutes of this, if that's...
Yes, Commissioner Briggs, that's acceptable? Yeah.
And I should check with you, Associate Professor Wallace, if you're happy for us to keep it a moment longer?
Yes. Fine.
Could I ask you to explain why it is your very strong preference for that embedded model? Why not an outreach model for the oral health therapist, the oral hygienist?
Because the facilities need to take responsibility for holistic care for the residents, and oral health is part of holistic care. If they're not made to pay the practitioner and then those oral health services are directly attached to their accreditation processes, then it won't happen. We've had research in aged care facilities for decades. We've had trainer-trainer programs. We've had people going in once every 6 months to provide dental care such as restorations, relief of pain, extractions. And that's all very necessary and we still need those things in place. But without a practitioner in the facility embedded within the multidisciplinary team, then oral health is forgotten and it becomes a luxury rather than a necessity. The research that we've carried out over the last 10 years backs that up as we send students into facilities once a year and only for one semester, and things are not even there after 1 year. So we know that without an on-site qualified practitioner within the multidisciplinary team, oral health will never change for our frail and elderly.
Who holds the funding, in your view, or who ought to be holding the funding for the model?
I believe that we need Commonwealth funding for a rollout for the Senior Smiles program. Because it's a preventive oral health program, it's able to triage all other oral health needs. So if we had Commonwealth funding for the Senior Smiles program that went to the aged care facilities, that was linked to their accreditation processes, much like nutrition is linked to accreditation processes, and the facilities must have a certain number of nutrition visits per calendar year, then the responsibility comes from Commonwealth funding to fund the program. The facilities then take responsibility for providing holistic oral health care to their residents. And then the Senior Smiles practitioner can act as a triage agent who then filters out the residents to the most appropriate dental care. So those residents who are entitled to public dental services would go to the public sector. Those that are able to pay for private practice would go to private practitioners. So the Senior Smiles model really is the model that is able to control the flow of oral health, but it will then send those residents to whoever they are most appropriately need to go to. So it's public sector or private sector.
How does access to dentists and other oral and dental health practitioners work on the ground with the Senior Smiles model?
With the Senior Smiles model, we develop really strong relationships with community dentists, public sector dentists and private sector dentists, and also dental prosthetists. It's really important to build partnerships with local practitioners, because if you have people coming in from a long way away and they're coming in once a year or once every 6 months, then they're not there to pick up the pieces if the resident has a tooth out on Friday and on Monday has facial swelling or has a restoration that breaks. We need to manage our aged care oral health population with our local practitioners, because then they also get ownership of that oral health, and also the facilities then become very attached to those community dental practitioners, and it's a win-win for the residents, for the facility, and for the practitioners within that community.
Do you have a view as to how the outcomes for the resident can be measured, and in reflecting on your response to that, what you would like to see the provider, the facility, to be assessed against in the accreditation that you referred to?
Sure. I would like to see the accreditation processes have to show that they have a qualified preventive oral health practitioner on staff who works within their multidisciplinary team, providing preventive oral health care with the team on a day-to-day basis, identifying any oral health issues that need to be dealt with, and then managing referral pathways to those practitioners. I would also like to see some documentation that residents on a day-to-day basis have their teeth brushed, their dentures cleaned, their mouth swabbed, just as they document toileting and showering and feeding and medication. Currently, that's not done in aged care facilities at all. There is no pressure on them through the accreditation processes to show that oral health is delivered in any way on a day-to-day basis. That's unacceptable. Oral health is part of general health, and the residents deserve to have holistic care.
Have you observed a relationship between those oral hygienists, those oral therapists that have been engaged under the Senior Smiles model to a facility, a relationship with the personal care workers that are on the ground in the facility?
Yes, definitely. The staff within facilities welcome an oral health practitioner such as the Senior Smiles practitioner. The Senior Smiles program is endorsed by all professional associations, including the New South Wales Nurses and Midwives Association. The nurses and the care staff tell us that they want someone on site who can identify oral health needs, who can assist them if they have residents who may have challenging behaviour due to cognitive impairment. They want somebody on staff that can help them address these issues. And the other thing about having a Senior Smiles practitioner on staff is that we can identify simple issues that can be dealt with quickly and cheaply and easily, such as xerostomia, dry mouth, or candidiasis, thrush. If you don't have a qualified oral health practitioner, those things are not able to be picked up. So the Senior Smiles practitioners can deal with small, minor issues that really can have a very detrimental effect on quality of life, but they also identify the bigger issues and then are able to refer to dentists, dental practitioners, dental prosthetists in a timely manner.
When the referral to a dentist or a dental prosthesis is occurred as a result of that engagement, that interaction with the Senior Smiles practitioner, is that done on an outreach basis, or is the resident required to travel? How's it facilitated?
It's facilitated in a number of different ways. So some residents will go out to a local dentist if they're able to, and some dentists will come into the facilities. There are a number of dentists that will come in with portable equipment and deal with the residents in their facilities. Ideally, moving forward, an ideal situation would be that all aged care facilities have an on-site dental clinic so that residents can be looked after within that environment. Many residents with cognitive impairment find it very stressful leaving the facility and going out to have dental treatment. So in the Senior Smiles program, we try really hard to assess the residents' needs. If they're able to go out to a dentist, then we will suggest to their family or their carers that they do that. And if not, we work really hard to get one of our practitioners to come in and provide the services within the facility.
Your model is focused on the residential setting. Have you contemplated or given any consideration to how recipients of aged care who are living at home, receiving CHSP or on a home care package, could access those oral hygienists, those oral health therapists, which is...
The Senior Smiles model is transferable to any environment where somebody needs an oral health risk assessment, a care plan developed and referral pathways set up. We a number of years ago, we had our Senior Smiles practitioners at the Woy Woy Public Hospital in the geriatric ward providing exactly the same service. We're about to start another research project in a hospital ward. Senior Smiles practitioners could do home visits much like the community nurses do. In fact, they could work with the community nurses. It's translational, transferable to any environment. It would also work really well in special needs environments and that sort of thing.
What would practically need to take place for the Senior Smiles model to work in a home care setting?
That would need some discussion about the funding, and I don't think I want to comment on that funding at this stage, but it certainly is something that could be done. If we're looking at the model where the community nurses go out, then I guess we could look at a model where perhaps, again, public hospitals or aged care facilities employ oral health practitioners, and then they could go out in a model similar to the community nurses. I can see that would work well.
Returning to the draft propositions, Proposition D1 contemplates funding public dental services to provide outreach services to Australians accessing aged care services in their place of residence. Could I ask you to consider whether you think Proposition D1 addresses those oral and dental health outcomes of the older person in combination with those broader issues that you have indicated stem from the oral and dental health of the older person?
I'm sorry, I don't have that in front of me. Is it possible for someone to read it to me?
I'll ask the operator to bring it up. It's at RCD stop 9999 stop 0343 stop 001 stop 009 and 10. And I can indicate that on the document that you've responded to the draft propositions on, it's on page 1 of that correspondence to the Commission. So that's just been brought up on the screen now, and you'll see it's in the second half of the page under, and it goes over to the next page. I can ask the operator to bring up page 10 as well. So my question is around a way of addressing.
Yeah. So in addition to funding for the Senior Smiles program, I would like to see funding provided for outreach services, much like the chronic disease, now defunct chronic oral disease program that we did have, so that older people who meet the criteria are able to access funding through Medicare to provide their dental care. I would also like to see that anyone who's 75 plus has access to a Medicare funded oral health examination. So there's really two parts here, and the Senior Smiles program plays the preventive role here and the triage role to all these other all these other models that require funding for the actual restorative dentistry work that needs to be done. But the Senior Smiles program is the beginning of it. It's how we can actually manage oral health in an equitable way that until now has not been done for our frail and elderly. The other outreach services, yes, do need funding, but the Senior Smiles model is able to direct residents to public sector funding and private sector dentistry. And I think that that's a very strong case for the Senior Smiles program, because it will identify where these people need to go and provide a distribution of workload to whoever is responsible or whoever the resident can have access to, depending on the funding.
And in respect of access to a model such as Senior Smiles, is it your view that it would be available to all those who are in receipt of aged care services, or is a means-tested approach something that's been contemplated?
No, absolutely not. The Senior Smiles program should be provided to all residents who are living in aged care facilities, regardless of their financial status. Oral health is part of general health. Residents are not means tested to see if they get assistance with showering or toileting or giving them their medication. It needs to be part of core business within the aged care facilities on a day-to-day basis, delivered to everybody, part of holistic care for our residents in aged care facilities. Absolutely not means tested at all. It's for everybody.
And drawing on the pilot, drawing on the research in the second phase of Senior Smiles, how can the oral and dental health of older Australians become the core business?
It's very simple. There is a very simple solution. If funding is provided for the Senior Smiles program, then there is a workforce available to work within the facilities. As part of our Senior Smiles program and our research, we have developed a CPD course for qualified practitioners. We've delivered that in many states already in Australia. So there is a workforce available to go into that environment if the funding is given to the aged care facilities to employ oral health therapists or dental hygienists. We have lots of practitioners who are very interested in working in this environment, and the model could be rolled out very quickly. As I said, the training is already developed. We've already delivered it in a number of states, and it works very well.
Commissioners, that concludes the questions I have for Associate Professor Lawless.
Yes, thank you. Commissioner Briggs?
No, I found that very useful. Thank you. No questions from me.
Dr. Wallace, thank you very much. Thank you also for your patience in getting the oral aspect of our system working back again. It was very unfortunate, but thank you. And thank you more particularly, thank you for your contribution to our work. It's been really very interesting and most informative. So thank you very much.
Thank you. Thank you, Commissioner.
I may now formally excuse you from further attendance. Thank you.
Commissioner, that concludes the evidence for today. I understand tomorrow that we're doing evidence at 10.
Yes, we'll adjourn now till 10 o'clock tomorrow.
The Royal Commission is now adjourned until 10 a.m. on Thursday, 16 July 2020.